Edward, you will be starting with your presentation.
Okay.
I don't know. I mean,
I will be starting. I'll just speak a few words first.
Okay.
Yeah. We'll wait for 2 minutes. We'll start at 6.
Yeah. How many people are joined?
28 only still.
Okay.
Just
If you give YouTube link, most of them join YouTube link only.
yeah.
Because the data consumed in YouTube is
Yeah.
less than Zoom.
We can't.
When I was conducting online
Yeah.
anesthesia, most of my postgraduate will join only in the YouTube.
Yes, sir. Yes,
Data
sir.
consumption is very low in YouTube.
Yes, sir. Yes, sir. What about the clarity of the picture, sir?
Oh, so okay, nice.
Okay. No. Any difference in the Zoom and YouTube clarity?
Clarity is same.
Clarity
I
same,
have
huh?
tried with Anesthesia TV.
Okay.
They telecasted.
Okay.
When I have joined late, even I join on YouTube only. Then I can start from first. I can start watching from beginning.
Yeah.
And you can save the YouTube link. So that's an added advantage.
Yeah.
Shall we start?
Yes. Rajesh Rao is coming.
Dr. Rao is.
Doctor, any
Rao sir has just joined.
He's joined. I think he left.
No, he came back.
Yeah.
He came back.
Hi, Chandni.
Hi, ma'am. Hi, ma'am.
How are
Hi.
you?
Good, ma'am. Actually, ma'am, there is no, we didn't get mail only to join.
Oh,
That is why people, I think, are struggling. I haven't got any mail.
when you registered, you did not get a mail?
No.
If you are registered, you have to get
Can you hear me properly, ma'am?
Yeah.
Yes. Your connection is proper.
The connections are proper, no?
Yeah.
Okay, even the
Yeah.
speaker
Am I
is okay,
audible?
no?
we got the
Am I
mail the same
audible?
day we registered, actually.
Yes, sir, you are audible.
Good evening, Rajesh sir.
Good evening, everybody.
Good evening.
I think it's 6-1, madam. Amola.
Dad? Or should we wait for some time or?
No. We should start, madam. People will join. We start.
Okay.
Shana,
So
one more thing. When I'm introducing you, you have to project your CV slide. Okay?
Okay, I have to project. Okay, sir. Yeah.
Okay.
So good evening, everybody. As president of Indian Society of Anesthesiologists, Borivali, I invite you all for this very interesting webinar on respiratory system and anesthesia. We are very fortunate to have with us three extremely esteemed speakers who are world-renowned. We have with us Dr. Edward Johnson, Dr. Naresh Paliwal sir, and Dr. Shiv Kumar Singh sir. We invite you all for this webinar. Thank you, SAMS, for giving us this opportunity and this platform so that we can bring all these esteemed speakers together. I now hand over to Dr. Rajesh Rao, who actually thought of this webinar. Dr. Rao, over to you. Your voice is breaking, Dr. Dr. Rao, your voice is cracking.
Am I audible
Yes.
now?
Yes,
Yes.
sir. Yes.
Sir.
I'm very sorry. After the success of your mark on Boruri 24, with more than 400 registrations, we are now on our webinar series under the SAMS platform. And today the topic is respiratory system and anesthesia. And as Kamala Madam has said, we have great stalwarts who are huge in their own field, who have graciously agreed to be a part of this webinar, in spite of the busy schedule. Special thanks to Dr. Shiv Kumar, who agreed to join us from a different time zone on a busy Friday. He said he'll be joining a little later, around 7:30. So without wasting much time, I hand over the proceedings to our MOC for the day, Dr. Chana Desai, who will take you forward. Chana, your CV, please. Chana Desai is a consultant, private anesthesiologist, member of ISA Boruri. He was past consultant at JB Wadia Children's Hospital. He was faculty at ISA Pune 23, Mahayuva 2023, Maha State CME 2022. And she has the Best Paper Presentation Award and on Perioperative Anesthesia and Shiv Mix in short surgeries. And she is presently the associated editor of our e-bulletin, the webinar. Dr. Chana, please take over and let it be a fantastic webinar.
Hello, sir, and all the respected faculty. Thank you so much for giving me this opportunity. Am I audible, sir? Is the video and everything audio clear
Yes, sir.
for all of us?
Very well.
Okay. So thank you so much for giving me this opportunity. Let's just start our program. The most common complication as an anesthesiologist is the beep of the monitor. We all know, and even in our sleep, can hear the tone of pulse oximeter going down. And we don't even know, it's just an instinct that yes, things are not going right. So our whole webinar today is at this brilliant topic of respiratory system. And we are going to deal with multiple complications that we encounter regularly, troubleshooting, ways of going about the different kind of surgeries, and more complicated patients now coming to us. All the more necessitates that we go thorough in our research before we take on any patient. So let us start with the first topic of the day. And let me first introduce our first speaker. Our first speaker is Sir Edward Johnson, sir. And sir, hello, sir. Are you there?
Yes, yeah, I am able to hear you, madam.
Okay, sir. So our first speaker is Edward Johnson, sir. And sir has been working as an HOD in Kanyakumari Medical College, and he's from Kanyakumari. And most importantly, sir has been very famous because he has his own YouTube channel and it has been doing really well. I mean, all of us youngsters and all the yuvas who have been watching the online anesthesia videos and the most popular anesthesia news, which is there on Facebook. It is very helpful for everybody. Plus, he is multifaceted. Sir has been giving lots of lectures. He has been awarded lots of memberships. Sir is also a part of IJA and DAS Society. And the latest award that Sir has been gotten is from the appreciation from the TN government. So without taking too much of the time, and we
Chana,
all
can
know.
can you please project the CV?
Sir, is it not
He
visible?
is not seen on the
No, it's not.
Is it visible, sir?
Yes.
Yeah. So
Can you
this
make it
is
full screen?
It is full screen only, sir. Here.
Right. Okay.
So this is Sir's CV, and these are his achievements. Sir is currently even a publisher for various journals, and he has done a lot of presentations also. And Sir's YouTube channel is very famous along with the Facebook channel. He also has an online anesthesia teaching on the Zoom platform as well as for Facebook. And he is interested in obstetric anesthesia and airway management. So can we begin with the first presentation by Edward Johnson, sir? Perioperative bronchospasm, the rise and the fall of EtCO2 or saturation that we commonly encounter. So over to you, sir.
Thank you, madam. Thank you for your kind introduction, madam. Can I share my slides, madam? Am I
Yes.
audible? Am I audible?
Yes, sir.
Yes, sir.
Can I share my slides?
Yes, sir.
So good evening, one and all. At the outset, I thank the office bearers of ISA Borivali and office bearers of SAMS Academy for giving me a chance to present in front of delegates from all over the world. Thank you, ma. Thank you, Desai Mara. So the topic given to me is the perioperative bronchospasm in COPD under laparoscopic surgery. To understand this bronchospasm, first we must understand the COPD mechanism and the complications that may occur in the general anesthesia. So I am going to present this topic in the following headings, that is timing of the bronchospasm and mechanism, the advantages of lab in chronic obstructive pulmonary disease, and points to ponder in the laparoscopic surgery, and choice of anesthesia techniques, whether GE or regional anesthesia, and finally the intraoperative management of bronchial asthma, prevention and treatment. So bronchospasm can occur both in regional anesthesia and general anesthesia. The timing of bronchospasm is more important in case of the general anesthesia. It is more common during induction and maintenance rather than in recovery. Recovery, it is very less. First, we must understand how hypoxia occurs in the COPD. So in COPD, all of you know, there is a small airway collapse and airway trapping. So there will be a mismatch of ventilation and perfusion. So that may lead to hypoxia. Likewise, in COPD, the COPD patients will have a retention of carbon dioxide because the dynamic hyperventilation increases the work of breathing. So the inspirative muscles get fatigued. So that will lead to hyperventilation of the alveoli. And moreover, there is a reduced ventilatory response to plasma carbon dioxide. So that will also lead to accumulation of carbon dioxide. So these all lead to hypoxia and hypercarbia. The chronic hypoxia leads to pulmonary vasoconstriction, pulmonary hypertension. So the afterload of the right ventricle is increased. So right ventricular failure, and there will be edema and consequently death. So the advantage of laparoscopy in COPD is, all of you know, it is minimally invasive and minimal access. It reduces the stress response. It reduces the acute phase reactants, that is CRP, interleukin 6, and reduce metabolic response, but not much reduction in the endocrine response. So the reduced pain, acute pain is more of visceral pain rather than a somatic pain. So it will cause shoulder tip pain. So less analgesic consumption is used. So the postoperative interference with the pulmonary function will be less. So that is the advantage of laparoscopy. So less pain, less atelectasis, less respiratory infection. So if you go for a laparotomy or open surgery, there will be interfere with the diaphragm functions and also the pulmonary function, that will lead to atelectasis in the postoperative period. So there will be accumulation of the bronchial secretion that will lead to secondary lung infection that may lead to ARDS. So these complications can be avoided safely in laparoscopy surgery. So few points to ponder in case of COPD patients going for laparoscopic surgery. So all of you know the safe intra-abdominal pressure is 12 to 15 mm. During that period, even though the venous return is reduced, cardiac output is less reduced, and there is a upper displacement of the diaphragm, and there is a basal atelectasis and less interference with the breathing system. But when the IAPB, intra-abdominal pressure, raises to 16 to 20 mm, the venous return reduction is more and the athletics is more, that will lead to increased lung dysfunction. When it more than 20 intra-abdominal pressure, definitely there will be end organ damage. So there is multi-organ dysfunction will eventually ensue. So you know, the general anesthesia, generally the alveolar complaints is reduced. At the same time, the chest wall complaints is also reduced. So the FRC is reduced. So the airway pressure increases. Once the airway pressure increases, the air is diverted from the less compliant basal alveoli to the more compliant upper alveoli. So there will be ventilation perfusion mismatch that will lead to hypoxia and hypercarbia. Remember, if a IABP is 15 mm of mercury, it exerts a weight of 50 kg on the diaphragm. So simultaneously, the carbon dioxide also increased because of the less alveolar ventilation. But remember, the rise in ETCOT is in proportion to the IABP. If IABP is high, it is intra-abdominal pressure is high, the end-tidal carbon dioxide also increases. But a plateau is reached after 15 to 30 minutes. If any increase after 30 minutes, you have to look for the other causes of raised ETCO2. So in the picture, you can see the ETCO2 increased and it reaches a plateau after 15 minutes. Likewise, your PCO2 is also rises and reaches a plateau after 15 minutes. At the same time, the pH falls. So the choice of anesthetic techniques, you know, there are two types of COPD patients, pink puffers and blue bladders. The pink puffers have a normal ventilated drive and maintain normal PCO2, and where blue bladders are reduced ventilated drive and reduced carbon dioxide drive. So GA depends upon the four factors: the clinical state of the patient, whether the patient is a pink puffer or blue bladder, whether there is a complication of the COPD, if the patient is able to lie down without a dyspnea, if the patient is having a persistent cough. These are the status which decides the type of anesthesia. And foremost is the patient satisfaction and nature of the surgery planned, whether it is a upper abdominal surgery, thoracic surgery, and the duration of the surgery. Duration of surgery is more important, because if the surgery exceeds 2.5 hours to 4 hours, it is an independent predictor of postoperative pulmonary complications. So the choice of anesthesia, it may be a minimal anesthesia approach. That means you are not interfering with the spontaneous respiration. The patient will be taking spontaneous respiration. This minimal anesthesia approach is best for the lower abdominal surgeries and the lower limb surgeries. And maximal support approach means you are paralyzing the patient and take out the ventilation for maintenance of hypoxia and to avoid hypoxia, hypercarbia, and acidosis. You are paralyze the patient and take over the ventilation. That is maximal support approach. And the third one is the local regional approach, that is your block or local anesthesia. And better is anesthesia, laparoscopic technique is better. So the problems with GA is you will have a reduced FRC, reduced plosive volume, and reduced lung volume. But in COPD patients, you will have a increased FRC. And coming to the airway, there will be a reduced tone of the bronchial smooth muscles, and bronchial mucus clearance will be less. So the airway resistance will be increased. There will be accumulation of the secretions. So ventilator control, there will be ventilatory response to the hypoxia, hypercarbia, acidosis will be blended in case of COPD patients under general anesthesia. And pulmonary circulation, the inhalation agents has advantage of bronchodilation when it is less than 1 max. When it is exceeds more than 2 max, it suppresses the hypoxic pulmonary vasoconstriction 50%. So it is a double-edged weapon. In low dose, it causes a bronchodilator. In high dose, it causes a suppression of the hypoxic pulmonary vasoconstriction. And blood gas, also there will be a alveolar and arterial gradient difference on the oxygen and also carbon dioxide. So immune function, there will be reduced bacterial activity due to reduced bacterial, that is bronchial macrophages, and there will be increased release of pro-inflammatory cytokines. So this is the diaphragm. From this, you can understand the effect of GA on the diaphragm. The dotted line is spontaneous respiration. This this line is controlled ventilation. So at the end of expiration, if you see the diaphragm is high in the chest wall, that means collapse of the lower alveoli. So atelectasis in the lower alveoli it causes. But in spontaneous respiration, it is very low. At the end of inspiration, the diaphragm goes below compared to the spontaneous respiration diaphragm. So there is one school of theory that COPD patients retard atelectasis in the basal lungs because airway collapse causes air trapping and formation of the intrinsic PEEP that prevent the alveolar collapse. And second thing is there is a destruction of the lung elastic recoil. The elastic tissue in the alveoli is destroyed. So the lung alveolar compliance is increased, but the chest wall compliance is reduced. That also retards the atelectasis. And the third thing is, once the abdominal muscles are relaxed by your general anesthesia or muscle relaxants, the force applying on the diaphragm is reduced. So your diaphragm may be displaced caudally, so that it will make prevent atelectasis. That is the three things. But another school of thinking is, even though there is air trapping and FRC is increased, if you increase FiO2, there will be absorption atelectasis. What we have note in the general anesthesia is compression atelectasis. In air trapping, they can go for a absorption atelectasis if you are using high FiO2. So there are two schools of thought. And as you know, the COPD patients, they have a blended response to the hypoxic pulmonary vasoconstriction, and also ventilatory response to hypoxia and hypercarbia is also reduced. So problems with the regional anesthesia can be applied intraoperatively or postoperative pain relief. There are various types: spinal anesthesia, paravertebral block, continuous epidural, or CSE combined spinal epidural, or segmental spinal. Nowadays, there is increasing evidence to support use of regional anesthesia in case of laparoscopy surgery for COPD patients. But the problem with regional anesthesia is spontaneous ventilation may lead to hypoventilation. There is reduced response of ventilatory response to hypoxia and hypercarbia that may lead to hypoventilation. Then the hypercarbia and acidosis can lead to raised pulmonary vascular resistance and pulmonary hypertension. Inadequate muscle relaxation can cause coughing and bucking. That means a patient with dyspnea on lying down are not suitable patient for regional anesthesia, and patient with persistent cough is also not suitable for regional anesthesia. And high level of spinal may block the sympathetic, so inactivated parasympathetic tone may cause bronchospasm, but it is theoretical only. And there is a expiratory reserve volume may be decreased in case of obese patients, and that will cause decrease in the expiration and clearance of the secretions in the alveoli. So stasis of the alveolar secretions, and then that will lead to respiratory tract infection. And finally, ARDS. So the hypotension is another problem because pneumoperitoneum will cause hypotension, and your increased airway pressure in COPD will increase the intrathoracic pressure. That will also hamper the venous return. That will cause hypotension. So hypotension is a deleterious effect in case of a regional anesthesia for COPD patients for laparoscopic surgery. And prolonged procedure, patient discomfort and shivering is another deteriorating finding in a patients with regional anesthesia, and heavy sedations may worse than GA. Suppose the patient is anxious and you are giving so much of sedation, that will be worse than the GA. So the intraoperative management, coming to the bronchial asthma, intraoperative management of bronchial asthma in COPD, the incidence on generally the incidence is bronchospasm in general anesthesia is 0.2%. But in case of COPD patients, the occurrence of bronchospasm under GA is increased to 2%. So how to prevent this bronchospasm? You can give pre-medication. If the patient is not hypoxic, you can give pre-medication to reduce the anxiety. And giving anticholinergic atropine is controversial. One school of thought is it decreases the bronchospasm induced by vagal stimulation. And another school of thought is it increases the tenaciousity of the secretions, and that will increase the segmental collapse and increases the cough. Second, whenever possible, you can use LMA in place of endotracheal tube. There are some guidelines for use LMA also that we will discuss in the panel discussion. And you can use inhaled beta-adrenergic stimulants, that is SABA, short-acting beta-2 stimulants. Salbutamol can be used preoperatively to prevent the induction stimulated bronchospasm. This is intubation stimulated bronchospasm. But remember, inhalation of anticholinergics is better than the inhalation of beta-2 adrenergic in case of intubation related bronchospasm, because the intubation related bronchospasm are mediated through the vagus rather than your beta. So beta-2 adrenergic stimulants are of no use in case of a intubation related bronchospasm. So induction agents, you choose the induction agent appropriately. Propofol, it will suppress the airway reflexes. Ketamine, it has its effect of bronchodilation, and you can use volatile anesthetics at the time of induction also. And barbiturates, as far as possible, you try to avoid barbiturates because it causes bronchospasm. And at the time of induction, you can attenuate the pressure response with lidocaine and opioids. And short-acting opiates may be used, maybe fentanyl or alpha-fentanyl. If remifentanil is used, that is the ideal drug. And inhalation anesthetics, you use sevoflurane, isoflurane. Try to avoid desflurane because desflurane causes bronchospasm and increased secretions. And you go for protective ventilation strategy that we will discuss later. Then you choose a neuromuscular blocking agents that has a equivalent affinity for M2 receptors and M3 receptors. That is mecronium, rocronium, and pancronium. So coming to this reversal, you better to go for sugammadex with rocronium. Rocronium with reversal of sugammadex, because your neostigmine reversal will increase the secretion, at the same time increase the bronchospasm. So better go for rocronium and sugammadex reversal. So intraoperative treatment, first you must know the differential diagnosis. So according to the GINA and GOLD guidelines, you know GINA, it is Golden Initiative for Asthma. Golden Initiative for Obstructive Lung Disease is the GOLD. So according to the GOLD guidelines, the differential diagnosis is, it is mechanical obstruction of the tracheal tube may be the cause, or endobronchial intubation, pulmonary aspiration, pulmonary embolism, pulmonary edema, tension pneumothorax, negative pressure inspiration, cause negative pressure pulmonary edema, anaphylaxis, adrenal crisis, and heart failure. These all should be taken for a differential diagnosis. Then how come to a conclusion? So you auscultate on the chest, look for the SpO2, arterial blood gas analysis, and airway pressure. And capnometer, in capnogram, you can see the sharp fin appearance of the capnogram. So for audience, what will happen to the EtCO2 in case of a COPD patients going for laparoscopic surgery under GA? Whether EtCO2 will increase or decrease? You can type your answer in the chat box. EtCO2 in laparoscopic surgery in COPD patients under GA. So the treatment for intraoperative bronchospasm is, as I said, it is a beta-2 adrenergic stimulant SABA. You can use albuterol, formoterol, it is LABA. Formoterol is LABA, long-acting beta stimulant. But according to GINA guidelines, they differ the usage of epinephrine. And corticosteroids, you can use by inhalation or intravenous. If the secretion is thick, you can avoid inhalation, you can go for intravenous. And anticholinergic also, you can give intravenous or inhalational. Then you can increase the depth of anesthesia. You give additional propofol and inhalation anesthetics. I already told you inhalation anesthetics is choice is sevoflurane and isoflurane, but MAC around 1 MAC, not more than 2 MAC. 2 MAC will suppress the hypoxia-pulmonary vasoconstriction by 50%. So these are other drugs can be used. Epinephrine, which is not recommended by the GINA guidelines. You can give magnesium sulfate and glucocorticoids. And these are not included in the guidelines, but cases are reported. Nitroglycerin, Heliox, and ECMO can be used. So coming to this general principle in general anesthesia for COPD patients in laparoscopy is, as far as possible, you try to avoid the dynamic hyperinflation. How to avoid the dynamic hyperinflation? You have to allow more time for escalation. That is, IE ratio should be increased. Intrinsic PEEP can be counteracted by application of external PEEP. So if the intrinsic PEEP is 10 centimeter of water, you have to apply extrinsic PEEP that is less than 80% of the intrinsic PEEP. That is less than 8 centimeter of water you can apply. That will counteract the intrinsic PEEP. That will keep the small airways open at the end of inspiration, so the alveoli air trapping can be avoided. Then you go for a treatment of bronchospasm with bronchodilators and deepening the level of general anesthesia. And you can go for recruitment maneuver to open up the collapsed alveoli in the base of the lungs. That is 40 centimeter of water for 8 seconds. Even after all these measures, if the airway pressure is high and if the expiratory tidal volume is low, you can shift on to pressure control ventilation. But there is no evidence for pressure control will improve the ventilation. But definitely the pressure control ventilation has a deceleration flow, so it will increase the tidal volume and improve the complaints of the alveoli and the chest wall. So coming to the last point, so why I have even deviated from my even bronchospasm, because these 2 points. Now you can say, wow, what is the cause for desaturation during COPD patients in laparoscopic surgery under general anesthesia? You can understand what I have told, because of the basal atelectasis and also the air trapping, dynamic hyperinflation. The air in the basal lung is diverted to the more compliant alveoli, so there will be ventilation perfusion mismatch that will lead to hypoxia. So that is the reason for desaturation during COPD patients in under laparoscopy surgery under GA. Whenever we have COPD patients going for desaturation, we will discuss the EtCO2 now. What will happen to the EtCO2? Will it increase or decrease? So it will initially increase according to the IAP, that is intra-abdominal pressure. If the intra-abdominal pressure is high, the EtCO2 will be also high, and it will reach a plateau at the 15 to 30 minutes. If the EtCO2 continue to rise after that, you have to look for other causes. But I am saying the answer. In COPD patients under GA in laparoscopic surgery, the EtCO2 will definitely fall, because if there is a fall in EtCO2, first you look for the hypotension, because your pneumoperitoneum also causes hypotension. Your raised intrathoracic pressure also hamper the venous return and cause hypotension. So look for the hemodynamic stability first. If there is a hemodynamic stability, then look for other causes. So EtCO2, how it decreases in COPD patients, because the EtCO2 is decreased by 2 mechanisms. One is hypocapnic hypoventilation, another is bradycapnic hypoventilation. Bradycapnic hypoventilation means respiratory rate is reduced, but the respiration is in full depth. So the alveoli get ventilated, but the minute ventilation is low, so the EtCO2 is low. In hypopneic hypoventilation means shallow breathing. So the alveoli is not ventilated. As the airway pressure increases, the alveoli is less ventilated. If you see the if you see the expiratory tidal volume, it will be low. So the alveoli is hypoventilated. In that case also, the EtCO2 will decrease. So whenever the IABP is intra-abdominal pressure is increased, your EtCO2 is tend to fall because of the hypoventilation of the alveoli. So these are the 2 questions put forward for me to present in the presentation. So now you understand why desaturation occurs, what happened to the EtCO2 in the laparoscopic surgery in COPD patients under GA. Thank you, madam. Thank you, everyone.
Thank you, sir. That was really a very nice and concise presentation. And as usual, a lot of us have lots and lots of questions. So we shall start taking few questions from the chat box, and also I shall take a few questions from YouTube also, because people have started posting over there. So the first question which was asked was that why is a beta 2 agonist not useful in a case of bronchospasm when we have already intubated the patient? So this was asked by somebody in Zoom, that why is there no role of beta 2 agonist, or is there any role of beta 2 agonist if the patient is already intubated? I think that should be more like the question.
Beta 2 agonist is not useful during intubation induced bronchospasm. That is because that is mediated through the vagal nerve. Vagal response bronchospasm occurs. So in that case, you have to use anticholinergic. And moreover, a beta 2 agonist is used for a prophylactic. Once the bronchospasm occurs, it has less effect. According to the guidelines of Gold and Gina. Gina guidelines mainly says that it should be used in the prophylactic rather than treatment.
Okay. And so somebody has also asked that what is the role of ketamine for bronchospasm?
Ketamine is advisable for an induction agent, but it increases the heart rate. Your hemodynamic
Secretion.
changes will be hypertension will cause, and ischemic heart patients, you should not use ketamine. That is the drawback of ketamine. Otherwise, you can use ketamine as the bronchodilator for the induction agent.
Okay. And one question from YouTube channel: how do we treat negative pressure pulmonary edema?
Negative pressure pulmonary edema usually occurs in young individuals due to the upper airway obstruction, mainly laryngeal spasm. So you better avoid this negative pressure inhalation by earlier application of the muscle relaxants. We can relax the obstruction that is caused by the larynx obstruction, that is laryngeal spasm. You can avoid laryngeal spasm by using muscle relaxation at the earliest in young patients. That is the way to avoid the negative pressure pulmonary edema.
So you mean that if we are giving a relaxant, the chances of negative pressure pulmonary edema will be lesser as
Yes.
compared to a patient who is spontaneously breathing?
Negative pressure pulmonary is mainly due to the upper airway obstruction. You avoid the upper airway obstruction at the earliest to avoid the negative pressure pulmonary. That is simple.
Okay.
Otherwise, we will use relaxant at the last resort. But if you suspect young patients will have a vigorous inspiratory effort, they will easily go for a negative pressure pulmonary edema. In that cases, you can go for muscle relaxation at the earliest sustainably 10 million.
Okay. And so most of the times we've even seen if there's a bronchospasm, lot of practitioners end up giving aminophylline, derifylin. So what is the role of aminophylline or derifylin nowadays? What are the guidelines?
Aminophylline, they have removed it from guidelines because of
Yes.
the causes nausea, vomiting, arrhythmias, and seizures. So they have removed aminophylline long back from the guidelines. No more it is advisable. Aminophylline.
Okay. Yeah, because a lot of people, especially the little old timers, are very fond of giving aminophylline, but then the side effects are way too much. But then they always feel that that will only help us, because they have been using it for the years. And also, sir, we have seen people giving puffs through the endotracheal tube. So is there any other correct way of giving the puff in the ET tube so that more drug is there in the respiratory system?
Spacer, madam. There are collapsible spacer and non-collapsible spacers are there. It should be attached to the inspiratory limb, and there is one port for MDI. You can give the puff in the spacer, so attached to the inspiratory limb. That can be used during the GA, general anesthesia. And moreover, the dose will be 8 to 10 puffs because most of the drugs are deposited in the endotracheal tube. So you can increase the dose.
Okay.
So you can use inhalation spacer for the application of inhalation anesthetic during general anesthesia or ventilator.
Okay. So we need to give more number of puffs, 8 to 10 puffs usually. Okay. And so there is one more question. What is the role of magnesium sulfate in the treatment of bronchospasm? Is there any role for the magnesium sulfate in treatment of
Many cases are
bronchospasm?
reported in magnesium sulfate for bronchodilatory effect, but they are not included in the guidelines. But cases are reported, evidences are there. Magnesium sulfate is as a bronchodilating effect. Mainly, it is a central sympathetic suppressor.
So,
Unknown. Because
okay.
if it is a sympathetic suppressor, the parasympathetic will cause bronchospasm. How it is not causing? So,
Okay. And so one common scenario that everyone faces that when some patient who has COPD is posted for surgery, everything is going on very well. But when it comes to extubation, you see the patient is breathing well, you have good respiratory efforts, and you try to reverse the patient. But somehow after reversal, you notice that the respiratory efforts are not good. Suddenly there is increase in EtCO2. EtCO2 is through the roof. There is severe bronchospasm and there is almost rapid desaturation. So in such cases, what should be the line of action or plan of action, sir?
so after a extubation, you can
During
try
extubation, sir, prior. Yes.
after extubation. After
No,
extubation,
sir. Just after reversal, most of the patients we have seen,
extubated.
after reversal, they rapidly desaturate. Sometimes, not even, they have desaturated so much that you want to deepen the plane, and then you think
Yes.
that, okay, let's go in that way. But again, it's a whole
These
cycle.
patients are ideal for post-operative ventilation, elective ventilation. So you have to deepen the anesthesia and you plan for a post-operative elective ventilation. And moreover, bronchospasm, don't think the EtCO2 will go high because the alveoli is not get ventilated or the trapped gases will not come out. So how the EtCO2 will increase? So most of the things that there is bronchospasm, the EtCO2 will increase. EtCO2 will be a sharp fin appearance, may be the earliest sign, but as the time goes, there will be EtCO2 will get going for a fall in EtCO2.
Okay, and suppose we have extubated the patient, and after extubation, you suddenly see desaturation. These are some very common scenarios. So in private practice, what happens is, you are always, patient is extubated, you are getting a call for the next case. Even sometimes you have hastened extubation.
CPAP and BiPAP. Try with CPAP and BiPAP and give bronchodilators. If the patient is not improving, you can go for another intubation.
Re-intubation.
Most of them will recover because there is no irritation in the upper airway. You have already removed the endotracheal tube. So your CPAP, BiPAP with bronchodilators will definitely help in the after extubation.
Okay.
Rarely it need intubation.
Okay, sir. And are there any specific criteria or indications for post-operative ventilation in COPD patients, sir?
Definitely, there is. I thought I will discuss it in the panel discussion, but post-operative elective ventilation. What is the indication? If you ask me, you have to do a that is neuromuscular monitor is a must. You have to reverse only when the top is more than 0.9. That is 1 point. And in COPD patients, the end-tidal inhalation agent should come to 0 because there is a trapping of the air. There will be trapping of the inhalation anesthetics that will be slowly excreted at the time of extubation, reversal. So you have to wait for the end-tidal inhalation anesthetics come to 0. Then only you have to extubate. Otherwise, it will cause depression in the immediate post-operative period. And reversal also, it's more important. So these two things are more important before confirming the extubation. Otherwise, if there is not adequate reversal because of you using neostigmine and there is a bronchospasm at the time of extubation, don't extubate. You wait for the extubation. Go for elective ventilation and extubate later.
Okay. And there are few questions. One of them is, what is the role of adrenaline nebulization? So how do we give? I think what about even racemic epinephrine, as in adrenaline and racemic epinephrine, sir? Can you highlight about that?
Intravenous, we can give 50 mg, but most of the guidelines they say avoid adrenaline. But inhalation agents, you can give 1 in 1000, that is 1 ml, can be diluted to 10 ml, then 1 ml can be nebulized. 1 in 10,000, that is 1 ml will be nebulized.
Okay. So, and do you suggest nebulizing patients preoperatively? Like pre-op nebulize, if a patient, now we have this patient for elective surgery. So do you advise any preoperative nebulization, sir?
Preoperative nebulization helps in to avoid bronchospasm during the time of intubation. So you can nebulize with beta 2 agonist or upratropine bromide, that is anticholinergic. The timing is, the onset of action for beta 2 agonist is 5 to 10 minutes, but the onset of action for anticholinergic inhalation is 15 minutes. So you have to give the inhalation 10 minutes before the induction or intubation. They will definitely reduce the occurrence of bronchospasm during intubation.
Okay. Okay. So there are few more questions, but then it looks like we can cover it in the debate panel because that will be more effective. And I think a lot of major queries about bronchospasm have been solved, sir. Thank you so much, sir. And we will now move on to our next topic about segmental spinal. And to give the topic, we have Dr. Naresh Paliwal, sir. And sir has been suddenly when we were students, we had learned about spinal, and we had learned things that you cannot give spinal above this level. Oh my God, how are you introducing the needle? What is this thoracic spinal? There were few things that we had been learned, and it's like a big difficult topic in everybody's mind when it comes to segmental spinal. So, sir has been pioneering this, and we are grateful to have him talk on this. Can we see the CV slide of sir? Paliwal, sir? Is it visible?
Yes.
Okay. So, formally introducing Dr. Naresh Paliwal, sir. Sir has been a faculty at various state, national, and international conferences and forums. He has more than 50 presentations on segmental spine in the last 3 to 4 years, 6 live workshops and 8 interactive workshops and master classes, more than 6 publications, and 2 on DexCat in national and international journals. Sir had a best paper on DexCat for Ludwig's angina on Isakon, Maharashtra. And he is published recently a handbook on segmental spinal in 2023 in the book of Anesthesia and Critical Care. So, and we have seen Sir speak about segmental spinal, and we know how difficult it is initially to accept the fact about segmental spinal because of the teaching. But now everybody has found out that there are few distinct advantages. But I think Sir is the best to speak upon this, and I'll hand over to Sir to start a presentation on segmental spinal, and then we go with the debate, sir.
Hello, good evening, everyone.
Good evening,
I'll
sir.
just share my screen if I am able to. Is my screen visible?
Yeah.
Mm,
Not yet.
Not yet. Like to record this computer's open system settings. Just a minute. Just now change my laptop, so I'm not able to.
no problem, sir.
This is the first time I'm doing from this MacBook 3. Now is it visible?
Yes, sir.
Yes, sir.
Okay. After a very good presentation by Dr. Edward, it's my presentation on role of segmental spinal anesthesia in patients with respiratory illnesses. Actually, it's difficult to cover the topic within 10 minutes, but I'll try to restrict myself to the utility of segmental spinal in patients with respiratory illnesses. I hope I am audible.
Yes, sir.
Okay. I'm very much thankful to ISA Borivali and all the organizers for giving me this opportunity. I'll start up with my topic. The new era on segmental spinal began in 2006. Actually, when Evan Zundert gave a segmental spinal for a patient with severe COPD for laparoscopic cholecystectomy. If you go through the internet in the recent 3-4 years, you'll see there are so many publications on segmental spinal. It's just flooded with publications, and especially in patients with respiratory comorbidities. I'll just show some of them, screenshots of the publications. Segmental thoracic spinal anesthesia for MRM in bronchiectasis patient, in patient who had undergone pneumonectomy. Then segmental thoracic spinal in patient with vessinosis undergoing nephrectomy. Then again, the segmental thoracic spinal for a laparoscopic cholecystectomy in a case of Bird-Hogg syndrome. The Bird-Hogg syndrome is a disorder featuring multiple lung cyst bulla, which lead to recurrent spontaneous pneumothoraxis. Then again, this was my presentation, my publication on segmental spinal versus general anesthesia in patients undergoing laparoscopic cholecystectomy. Then again, this thoracic segmental spinal anesthesia for radical nephrectomy in patients with amyotrophic lateral sclerosis. Then thoracic segmental spinal, useful alternative general anesthesia in patients with respiratory insufficiency. These are the publications in the last 2-3 years. Thoracic combined spinal epidural for lap chole in obese patient with asthma and multiple drug allergies. MRM in a patient with bronchiectasis using thoracic segmental spinal anesthesia.
So we
There
have
was actually
lost
Sorry to
your
interrupt, sir.
presentation, sir. Yes, sir. We
Pardon?
lost your presentation, sir.
Now is it visible?
No, sir. Suddenly we just lost the presentation.
I don't know what is happening actually. Now?
Yes,
Now
sir.
it's
Now we got it.
okay.
Can we start again, sir? Because we had just
There
lost
are
it.
just 2-3 publications about that.
Okay, sir. Okay.
I mean, nothing important in that. There was an article in the British Journal of Anesthesia in April 2022 about defining the role of thoracic segmental spinal in 21st century. And the conclusion provided was, despite the absence of larger trials, there's evidence from the small cohort studies and multiple case reports that thoracic spinal anesthesia may be considered as a safe, feasible, effective alternative anesthetic technique and may be used in patients. Maybe used in patients means in cases where other anesthetic techniques pose a high risk. That means you can use this in cases like COPD. Then again, there was an article in the next year, April 2023, about this role of segmental spinal in non-intubated video assisted thoracoscopic surgeries. And they mentioned that the trajectory of thoracic surgery and anesthetics holds a promise in the form of thoracic anesthesia armamentarium in the future. Now, the goals of anesthetic management in patients with respiratory comorbidities is avoidance of medications causing impairment of the mucociliary clearance, avoiding handing of the airways as far as possible to avoid the bronchospasm and laryngospasm, as mentioned by Dr. Edward. Then mechanical ventilation, then preventing atelectasis, ensuring adequate analgesia, and encouraging the early mobilization.
So sorry to interrupt, sir, but your slides are not moving, sir.
Not moving again?
Yeah,
sir.
so it's again stuck on the first slide only.
Okay, I don't know what is happening.
Yeah.
Now it's
Yeah, the risk factor slide is seen.
okay.
Risk
I'll go back.
complications. Maybe you need to go into slideshow, sir.
When I'm hiding these floating control channels, I'm actually losing the slides. Is it visible now?
Yeah. Yes, so now we saw
Yes,
some
yes.
change. Yeah.
Now the previous slide where I was avoiding handing of the airways as far as possible, mechanical ventilation, preventing atelectasis, ensuring adequate analgesia, and encouraging early mobilization. These are the goals in patients with respiratory illnesses. Now it's visible. Risk factors.
Yes, sir.
Risk factors for patients and complications. There are many risk factors for patients with respiratory comorbidities. Main important is the patient-related factors like the age, older age, then history of smoking. It makes the patients more prone for post-op pulmonary complications. Then associated cardiovascular diseases. Most of the COPD patients are having this right ventricular, cor pulmonale and pulmonary hypertension. Then obstructive sleep apnea in patients with obesity. Then procedure-related risk factors. The surgical site is most important. Like the upper abdominal and thoracic surgeries, they are more prone for this post-operative pulmonary complications. Then duration of the surgery, longer duration, like more than 2.5 hours. The patients are more prone for these complications, and positioning during surgery. Then anesthetic factors like sedative effects of the anesthetic agents, like use of opioids and sedative agents, which can lead to post-op respiratory depression and complications, airway manipulations, general anesthesia, and controlled ventilation. Using neuraxial anesthesia is not new, especially for the lower abdominal surgeries and below umbilical surgeries and lower limb surgeries. As a primary anesthesia technique for appropriate surgical procedures, avoid airway manipulations, sedative effects of the most anesthetic agents, but still have some issues of concern in such patients when routine lumbar spinal or epidural anesthesia is used as a sole anesthesia because of the paralysis of the upper abdominal muscles and intercostal muscles. The lumbar spinal is having some issues where you use a very large doses. And the advantages of segmental spinal or lumbar spinal. The surgeries which were thought to be out of domain of the spinal anesthesia, like upper abdominal, thoracic, and breast surgeries, are possible under segmental spinal. The higher levels of the block can be achieved with just half the dose than that is required at the lumbar levels. Lower doses of the drugs, they block mostly, being isobaric drugs, they block mostly the cells, produce a selective block that there are no respiratory issues even with higher levels of the blocks. There is minimal hemodynamic fluctuations, early recovery and voiding. Then there is lower incidence of post-op nausea, vomiting, post-op respiratory issues. I'll just go through very quickly about this, what is segmental spinal, because the time allotted to me is just 10 minutes. Everyone knows what is segmental spinal. The ideal definition is blocking out the required dermatomes with very low dose injected near the targeted nerve roots. Lower the dose, more likely to produce a true segmental block. Then there are some factors which make segmental spinal feasible. Thoracic level, the spinal cord is positioned anteriorly, nerve roots are slight and thin, amount of CSF is comparatively less. Then there are some concerns about segmental spinal. Can there be neurological injury, ventilatory impairment, bradycardia, hypotension, or medical legal issues? I'll just go very quickly through this. There is a sufficient space between the posterior and spinal cord at mid-thoracic levels, as by now everyone knows this. Then the Embelloni and Guia measured the exact distance, and they found the distance to be more at mid-thoracic levels. The spinal cord sits ventral in the apex of the thoracic core, and more so when we ask the patient to flex the spine. You can see here the distance between the posterior and the spinal cord. Because of the angulation that is required to perform spinal at mid-thoracic levels, the distance between posterior and spinal cord is further increased. Then some additional points. The incidence of neurological injury after accidental duropuncture in thoracic epidurals is very less. And many people, they use inadvertently a higher lumbar or even low thoracic spaces, especially in obese and parturients. Only 29% were found to be correctly identifying the level for giving spinal. And the level cord, the spinal cord termination is also variable. The second issue is ventilatory impairment. Here, the main inspiratory muscle of respiration is diaphragm, which is usually unaffected. Expiration at rest is a passive process, and forceful expiration and coughing may get affected. But because of the low doses of drug used, it is usually preserved. The heart rate may decrease block extending T1 to T4, but because of the lumbosacral sparing and less venodilatation, the right atrial filling is maintained, and that sustains the outflow from intrinsic chronotropic receptors located in the right atrium and great veins. Less hypertension is due to less sympathetic block. Medical legal issues. Now there is enough evidence for cases where it is most indicated. Feasibility. Technically, it's not very difficult and different. Economics, very economic. Legal, can be defended with strong indications, and can be operational at any setups. Indications, all intra-abdominal surgeries, whether it is open or lap, major, minor, upper, lower, they all can be done under segmental spinal or a combination with epidural or continuous spinal. Then breast, superficial thoracic surgeries, even awake thoracoscopic surgeries like bulectomy, thymectomy, lung volume reductions, prone, lateral position, spine, musculoskeletal, etc. Only thing is indication of segmental spinal needs to match the surgical needs of the patient. Then the different modes of using segmental spinal, either it can be single shot spinal for short to mid duration surgeries from 60 to 90 or 90 to 120 minutes. Then can be combined with epidurals when epidural can act as a backup for segmental spinal when you want to use a very low dose in the segmental spinal. Then by epidural volume extension, you can spread the low doses to wider segments. It can also be useful for post-op analgesia. And the third option is in a very critically ill patients, you can use continuous segmental spinal anesthesia. Drug options, either isobaric or hyperbaric alone can be used, or a combination of either of the two from the three can be used. Isobarics are usually preferred for lap and open surgeries in morbidly frail patients. Hyperbaric can be a choice in muscular patients. Hypobaric are usually not used alone. You all know the different isobaric drugs which are available: bupivacaine, gliobupivacaine, ropivacaine, and chlorprocaine. Hyperbaric drugs, there are 3 of them. Additives which will not cause much of post-op respiratory depression, post-op nausea, vomiting, early recovery, and voiding are usually preferred. Fentanyl, dexmedetomidine, or clonidine in patients with respiratory comorbidities. How to decide is, everyone knows by now, 1 ml spreads 2 to 3 segments above and below. That means 2 to 2.5 ml is sufficient for most of the surgeries of short to mid duration. 10 thoracic in the center of the surgical field. Dose of local anesthetic, additive, and site of injection can be varied according to need. For breast surgeries, spinal at mid-thoracic levels with just 1.2 to 1.3 ml, maximum 1.5 with additive. It can provide duration 60 to 90 or little more with dexmed as additive. You should combine it with some either epidural or some blocks for long duration surgeries. This is the chart I prepared for various surgeries, various sites of injections, the drugs that are to be used, and the levels it will achieve, and the blocks, different blocks which need to be given for post-op analgesia. Not go into detail. You can assess the motor blockade as you assess during the thoracic epidurals. Epidural scoring scale for arm movements. Then landmarks, everyone knows by now, the prominent spinous processor C7, then root of spinous scapula T3, inferior angle at T7. You can take the help of ultrasound for locating the spinous processes and laminar spaces, and pre-procedure scan, ultrasound scan can be done for safety. Ultrasound, it's almost similar at lower thoracic and upper thoracic levels, but at mid-thoracic level, it's slightly difficult. You need to do a parasagittal oblique scan for locating the interlaminar space. This is how it looks at in the parasagittal interlaminar view of the thoracic spine. The laminae are flat leaf-like appearance with very narrow interlaminar spaces. And if you are able to see the posterior complex and anterior complex, that means the space is open for giving spine. Transverse views of no use. Safety measures, preoperative assessment needs to be done. Then dermatomes involved in the proposed surgery. If ultrasound available, you can do a procedure scan, identify the landmarks, selection of the proper drug dose site and mode, assessment of the levels and proper monitoring. So to sum up, it's a very useful technique, many advantages. No need to panic if the block level is found to be higher than desired. It's mostly a sensory block. Lap surgeries may need a little sedation if adequate levels are not achieved. USG can be handy for more safety. This is some comparison between the segmental spinal and segmental epidural. As we all know, just 1 ml of the drug spreads 4 to 6 segments with segmental spinal. In epidural, you need 1 to 1.5 ml per segment. And the segmental spinal provides a dense, uniform, and has a definitive endpoint in the form of free flow of CFSF, while epidural at times can be patchy, especially in cases where there is previous spine surgery or some deformities. Chances of blast are there. The similarities between both of them is thoracic spinal and epidural. Both the techniques require injection in the middle of the dermatomes to be blocked. I'll show some videos. This is a 62-year male with hypertension, COPD for lap chole with ETCO2 monitoring under segmental spinal. Because he was a male patient, 2 ml of the drug at around T10 level with fentanyl as additive. This was a male MRM for ductal carcinoma in a patient with repeated chest infection. Bilateral capitations were present. Then segmental spinal with erector spiny plane block was given. This is erector spiny plane block is being done initially at T5 level with landmark guided method. Just 18 ml of the 0.5% LEOBPN was given. This is MRM being done, male MRM. It was very comfortable. This is at the end of surgery, and then patient shifting himself. This was a traumatic diaphragmatic hernia done under combined spinal epidural. Here the spinal was given first in the lateral position at T7-8, and epidural was given at T8-9. You can see the whole of the left hemithorax was filled with intestinal contents. Mesh repair being done. At the end of surgery, and the next day X-ray of the same patient, you can see the complete lesion of the left lung. This was a very critical patient, 62 years female with CS stomach, and she was an Adivasi patient having multiple comorbidities, pericardial effusion, pleural effusion, plus her his electrolytes were very deranged. Just potassium was 2.75, and sodium was also low. And if you don't operate these patients, they will take them home and let them die. So we decided to operate the patient early, tried to correct the electrolytes, but within 2 days it was not possible. So we planned for a continuous segmental spinal anesthesia. Because she was just 28 kg, I used a pediatric epidural catheter for continuous spinal at T11-12 level. The surgery was total gastrectomy, gastrojejunostomy, and jejunostomy. It was a 4.5-hour surgery. She required some NORAD support for time being, but it was withdrawn at the end of surgery, and she was moving in the evening. Then benefits of awake thoracic surgery. Awake spontaneously breathing patient, minimal or no handling of the airway, faster recovery with minimal post-pulmonary complications, shorter hospitalization, and non-inferior efficacy assumption over the conventional approaches. The procedures which are feasible under awake thoracoscopic surgeries are resection of the pulmonary nodules, wedge resection, VAT metastastomy, TAC pleurodesis, anterior mediastinal masses, empyema, and thymectomy in patients with myasthenia gravis. I have done few cases of thoracoscopic surgeries under segmental spinals. For knee VATs, there are various options available actually under regional anesthesia. Many people do it under intercostal blocks only, or thoracic perioperative blocks, or epidurals. But the advantages of segmental spinal over others is a quick onset. There is uniform lens block with minimal drug. No additional sedation is usually required. It's very economic with early recovery, minimal hemodynamic changes, and chances of loss are negligible. And disadvantage is only it has a limited duration and not useful for post-op analgesia. I show this knee VAT surgery done under segmental spinal with 1.2 ml of bupivacaine at T56, along with erector spinae plane block. It was a massive pleural effusion for thoracoscopy and pleurodesis. Actually, you can see the thoracoscopy is being performed. She was comfortable throughout, and no sedation was required. There is another method of doing the same thing, thoracoscopic surgery with unilateral spinal using hypobaric drugs. This also we did unilateral segmental spinal with hypobaric 0.2%, bupivacaine 3 ml at T7 at level for knee VAT surgery. For this, we kept the patient in lateral position, operative position, and used 3 ml of the hypobaric drug, taking 2 ml of the isobaric drug and 3 ml of distilled water, making it 0.2%, out of which 3 ml was given. The patient was kept in the same position with slight head up position so that it remains a unilateral block. There are many different methods of doing the same thing. So I have taken only few videos. The hypobaric drugs are a little unpredictable for spread. You can have some higher spread, but it hardly matters because the drug used is very minimal. There is no hemodynamic fluctuation at all. I'll just make it fast forward. These are my various publications, and this is my book published last year. So thank you very much for patient listening. I have to cut short this presentation just to save the time. So thank you very much.
Thank you so much, sir. And we wish we didn't have to tell you to cut it short because
I'm
understanding.
sorry, the presentation in some settings were disturbed because I changed my laptop. So
No, sir. We are quite in time, so we could have that thing also, and we were glad that we could see the whole thing. But we definitely want to see the presentation in more detail next time that we have the
yes, it
webinar
requires a
or
lot of time
conference.
for my segmental, but the topic was only for this thing, segmental spinal and all.
Yes, sir.
COPD patient. So I just cut short my presentation. So thank you very much. Any questions? I'll be very happy to answer those.
Yes, sir. So we are going to start the debate, and
Okay.
there will be a lot of questions during the debate scenarios. So practical questions during the debate scenarios, but one or two questions for segmental spinal. So which needle do you usually use, sir?
I
What
use
gauge and
27
which
gauge Quincke needle.
27 gauge Quincke needle. And you said you used pediatric epidural set for the
That
27
patient
gauge.
was, we have that interlong set specially available, but that patient was very poor and was done totally free of cost. Actually, she was Adivasi patient, and
Okay.
she was just 27 kg. So I used that pediatric epidural kit for that patient. It was a very frail patient, so it was useful in that patient.
So, sir,
Otherwise,
what
I
was the
used that
technique
interlong.
that you used for that? Can you elaborate a bit on the technique?
About the continuous segmental?
Yes, sir.
Yeah, you need to do as you do under this thing, your routine spinal. There are interlong catheters available with a 21 gauge needle and 25 gauge this blind tip catheter. It is just like your CVP guide wire. There is guide wire. I'll show the video if possible in the end about that continuous segmental spinal using interlong catheters. So you need to keep just 2 to 3 centimeters in the intrathecal space, and then titrate the dose accordingly. You need to keep the, the dead space of the catheter in mind. It is around 1 ml, 0.9 to 1 ml, and the initial dose should be around 1.5 ml, so that 1 ml remains in the catheter and only 0.5 ml goes. Then every 5 to 10 minutes, according to levels achieved, you can try to give the top-up doses, or you can use a normal saline to flush the catheter. If you don't want to use the initial dose as 1.5 ml, just give 0.5 ml, then use a normal saline to flush the catheter. This is just a titrated
Dosing.
spinal. Yeah,
Spinal.
till you achieve the desired levels, and then every 50 to 55 minutes, you can top up with just 0.5 ml of the whatever the drug you can use. You have the options of using isobaric, hypobaric, or hyperbaric, or even just intrathecal opioids. If you need, you can use those.
Okay, sir. And one question from the chat box. Do you routinely encounter PDPH when you have been using segmental spinal?
No, not yet. I mean, I've done at least 7,000-8,000 cases. It's just 0.1% or even less than that. Very occasionally, the patient complains, because we hydrate the patient properly, and actually we do a lot of daycare surgeries in segmental spinal. Yesterday only I did a lap poly. He was moving within 2 hours to bathroom. And day before yesterday did a lap TLH. She was also very high risk patient. They all are moving within 2-3 hours. So the incidence of PDPH is, very minimal. It's not like it's not there, but it's very, very minimal.
The
Just once
staff
in a
must be
year.
very happy when they see the patient moving,
Yeah,
especially when they have to shift the
it's a daycare
patient.
surgery.
Yes, sir. Okay, sir. Sir, I would also like to take the opportunity to welcome Dr. Shivkumar Singh, sir. Sir has just joined. He just finished his theater and he joined. And
Good evening,
now,
Dr. Shiv.
Hello, everyone.
good evening, sir.
Hi, good evening, sir.
So we are done with bronchospasm management by Edward, sir, and segmental spinal by Paliwal, sir. And now we are going forward in a small debate scenario kind of a thing, in which we have few case scenarios that we routinely encounter in practice, and we would like to go through the pros and cons and what are the guidelines and how we would tide over it. So I would just flash a few scenarios, sir. Is the screen visible, sir, to everybody?
No, not yet. Now it's visible.
Yes, now.
Tana, make it full screen.
Sir, I've made it full screen. 1 minute, sir.
Select slideshow, it will become full screen.
Yeah, is it now?
Play.
Yeah. Okay. So now we are going with the first case scenario. So we have a 55-year-old female patient. She's a non-diabetic and COPD since 5 years, and she's electively posted for lap cholecystectomy. Patient is on regular medication for her diabetes, and she takes salbutamol plus Budecort inhaler for COPD. Uh, her both her diseases are well controlled. She's an averagely built and normal BMI patient. On her examination, her chest is clear, saturation is normal with good meds, and so we have done her routine blood investigations, which were found out to be normal by the surgeon. Electrolytes were normal. They did a 2D echo also because the patient is a known case of COPD, which is also normal. Now the scenario here is that our surgeon is a bit fussy. He is the kind of surgeon who always complains about relaxation, and but our patient is very cooperative. So first of all, we would like to know that what kind of investigations would you suggest in this case? Do you suggest any further investigations like PFT, HRCT, ABG, or like how would a chest physician help us in such a cases? Because normally sometimes we write for a chest physician reference or optimization prior to surgery. So do you think any more investigations are needed, sir? Paliwal sir and Edward sir.
I don't think there are further investigations needed because her echo is normal, blood electrolytes is normal, and she is having meds of 6. So exercise tolerance, I like to examine her properly and ask about her exercise tolerance in detail.
Okay.
This patient, as a surgeon, is fussy. I would like to know in detail about the surgeon. I mean, how much time he takes for that surgery. Is he comfortable during regionals or not? And even if he is not comfortable in regional, but this patient is especially can be done very well under segmental spinal. And if the surgeon is not comfortable, you can combine general anesthesia using a LMA, very light general anesthesia along with segmental spinal. There is no harm in combining the two techniques together for the safety of the patient.
Edward sir, can we know your views about this, sir?
It's an elective case. I think it is well prepared case. The patient is, everything is under control. No further investigation needed. If at all needed, I can go do a ABG. If the ABG is normal, further PFT is deferred. And regarding this patient, surgeon is tense. I will prefer general anesthesia. That too, the patient is you have mentioned BMI less than, that is average. So it is a criteria for LMA. So I can put the patient on LMA, second generation LMA under GA.
Okay. So what is your Paliwal sir, what is your specific criteria for segmental spinal? Now, according to you, this case can be done under segmental spinal also. So what is the specific selection criteria do you have? Like if you go to see,
I always say that don't force your surgeon to do it under regional unless he is used to doing it under regional, because surgeon's comfort, patient comfort is the prime role. But you can always suggest your surgeon the safety about that particular patient, and you should be always prepared with the backup plan. So if needed, I convince my surgeon saying that if at all you feel anything disturbing you, I'll give general anesthesia without saying anything. So just do it, and many times it is done under segmental spinal alone.
okay, sir.
Madam, we are traditionally taught as the patient safety is the first, surgeon safety satisfaction is second, and the anesthetic satisfaction is the last. So if my surgeon is anxious, I will give more importance to his anxiety, and I will go for GA with
And so you would go for GA with controlled ventilation or
LMA.
GA with LMA. And for analgesia, what would be your treatment, your management of choice?
Because it is a laparoscopic surgery, the diaphragmatic interference or PFT interference in the postoperative period will be less. We can manage with, if we are extubating the patient, we can go for a tab block, subcostal tab block, or port infiltration with local anesthetics. And in addition to that, you can go for NSAID and patient controlled narcotics and analgesics.
I would slightly differ actually. I would like to know about her history also, about the steroid use. If she's using it, because many patients of COPD, they are using very rampantly steroids. If she is dependent on steroids, then we'll have to support interop with steroid supplements. And
No, sir,
before
she is
giving
not
them,
on any oral steroids. She's just on the inhaler, salbutamol and butyrate.
okay, then before proceeding for general anesthesia, even though there are the beta 2 agonist and all these things are not very helpful in COPD patients, they are more helpful in asthmatic patients. These COPD patients have a irreversible narrowing of the airways, but prophylactically you can nebulize the patients preoperatively just 10-15 minutes. Then I would rather use Dexmit, which is a very good drug. It can control everything. Then non-sedative analgesics and avoid the opioids, long-acting opioids. If at all I have to use, I will use remifentanil is not available with me, but I will use, if required, fentanyl or other drugs like paracetamol, diclofenac, and multimodal analgesia, even magnesium if required.
Okay. Shiv Kumar Singh, sir. So, what would be your take on this case, sir? Would you prefer to give spinal or would you go for GA?
Decision to give anesthesia is between me and the patient. Right? You give informed consent. You'll ask patient what she wants. If she wants to go to sleep, you put to sleep. It has nothing to do with surgeon. It's nothing to do with anybody else. It's a decision which you take between yourself and the patient. You need to look at what patient wants. Okay. If the patient wants to go to sleep, that's fine. If she wants to be awake, then you start thinking and discussing what it is. You need to present pros or cons of both. Let the patient decide, and that's what you actually will give. Now, coming to this scenario, the patient seems to be well controlled as far as that. But what you haven't said that, has the patient ever had any exuberations? Has the patient had any hospitalization? Has patient
No,
ever
sir.
needed to actually take a short course of steroids for acute exuberation? All patients who actually have history of COPD before surgery should actually have pulmonary function tests. You need to know what is the ratio of FE1 by FVC, because that decides how well controlled the condition is. I will obviously discuss a lot of these things when I present about asthma and COPD patients, so I'll likely talk about them. In normal scenarios, I think we reserve the segmental spinal for complex cases or patients where they want to remain awake. For awake patients, again, depending on now you need to actually think about what the intra-abdominal pressure is going to be, or what the surgeon uses, and will the abdomen actually support it? Now, this patient is 55-year-old, assume it's a multiparas patient. They usually have lax abdomen. You can use a supraglottic device, and we use all the time. But now you see patients coming for lap chole in young patients who have good muscle tone, or it was a male patient. When male patients can present with gallstone disease. In those cases, it's better to actually just go for endotracheal tube with a neuromuscular blockade. And even with with second generation supraglottic devices, if we have to use a muscle relaxant, you can actually use it. For some other patients, we actually put an iGel in, put an NG tube. I put NG tubes for all of this because I do these cases with iGel. Put NG tube, let it on free drainage, and depending on how the surgeon feels when the pneumoperitoneum is created, I would either let them actually continue, or I could give a short dose. We have we used to have mivacurium, it's not as much now. Use mivacurium, which reverses on its own. If not, you can use smaller dose of you don't require a bolus dose. You can give small dose of atracurium, 10 milligrams, or you can actually use cisatracurium. In patients, I prefer to use cisatracurium with COPD or asthmatic patients. And, you can in the end reverse them. Or even you can use rocuronium, whatever you want. It's not a problem. It all depends on your resources. And what do I do for analgesia in these patients that don't use any opioids at all? I do opioid-free anesthesia for this patient. I give subcostal tap on the right side and do a rectus sheath block for this. So going from the perambilical to the xiphisternum, do a rectus. We don't require anything on the left side. Everything is on the right side. Use multimodal analgesia, so paracetamol, and then the magnesium sulfate is the usual ones. Now you need to actually ask how tolerant are the patients to non-steroidals. Not everybody can get non-steroidals. You will find patients, a subgroup of patients who say they do not tolerate the non-steroidals. They can become, have symptoms with use of non-steroidals. So do ask them. That is a common thing. Asthmatic and COPD patient always ask, are they intolerant to non-steroidals? If they are not intolerant, then I would actually we use diclofenac IV. I give 75 milligrams diluted 20 mL of saline. And most of these patients actually are absolutely fine in the recovery now with this regimen.
Okay, sir. So that was one main important part for the simple patient is in any COPD patient, we need to know about the medicines the patient is taking and how much is the dose, any frequency of exacerbations, and the need for steroid, which is there, dependency. Okay, that is one thing that we took from this case. Now we have a second scenario in which the patient is a known COPD on inhalers, but she had her last exacerbation 3 months ago. And after that, she's a defaulter, not regularly taking any medications. But currently, when she comes to us, she's for her lap hysterectomy. Clinically, her chest is normal, saturation is 97%, and meds are around 5-ish. She does investigations are normal. 2D echo is normal, which we had done because she long-standing COPD. But her one issue that was there is she's obese. Now she's an obese patient coming for lap hysterectomy. Other systemic examination is normal. So in this case, what other investigations should we go for? Should we go for PFT, HRCT, ABG, and any role of any physician? How can they help us in this? Chest physician's opinion. Again, our second question is our plan for surgery. Should we go for GA? Now, if we are going for GA, do we intubate or do we keep on LMA? And so we need to know basically our selection criteria for GA also. So can we start with Edward, sir? So what would you give other investigations and your plan of anesthesia?
I go for ABG, and if there is a hypercapnia or hypoxia, I will do PFT to predict the postoperative pulmonary complication, to get the concern for the patient and to plan according to the postoperative pulmonary complication. And regarding this anesthesia, I will go for general anesthesia with ETT because the patient is BMI is more than 30, he is obese, and the position used for the laparoscopy surgery is Trendelenburg position. So that I have to prefer endotracheal intubation with positive pressure ventilation.
Okay. Paliwal, sir,
I would like to know about the history of obstructive sleep apnea in this patient because she is an obese patient. And if the surgery is not very urgent, I would like to have some pulmonary rehabilitation in this patient, like some exercises, pre-op exercises, weight reduction, then incentive spirometry can help. Then this is an obese patient. If the surgeon is not very quick and comfortable, you will need a general anesthesia with all backup plan for difficult intubation. But beforehand, I would like to know about the history of obstructive sleep apnea and pulmonary rehabilitation. That means whatever days we can have, we can give her some incentive spirometry and physical exercises about increasing the inspiratory negative pressure, this thing, and exercises, so that patient is comfortable after the surgery.
Okay, so would you consider CAC in this patient? Suppose if she has no OSA.
She is an obese patient and might not be very comfortable during the very steep head-low position because of the weight of the abdomen, and would like to know what type of obesity is. Female patient mostly have a gynecoid type of obesity. It's not very much or the neck circumference and all, but mostly on the abdomen and this hip region, gynecoid type obesity. But still, the patient may not tolerate the position for a long time. So you can use epidural or spinal along with general anesthesia, so that comfortable relaxation can be provided with spinal anesthesia, and together you can combine it with general anesthesia. You won't need much of the things, and dextromit can be very useful in such patients. Tiva.
Yes, sir.
And I like to combine spinal epidural with this GA, because the intraoperative period, you can get a relaxation, abdominal muscle relaxation in this obese patient. You can use less intra-abdominal pressure, and the pressure on the diaphragm will be reduced, so the basal atelectasis will be reduced. So intraoperative airway pressure can be reduced by combining a spinal anesthesia with the general anesthesia. And epidural can be top up in the postoperative anesthesia. So the diaphragmatic interference and PFT interference in the postoperative period will be also reduced. So the lung expansion will be better maintenance of oxygenation and carbon dioxide in the postoperative period also. So better for postoperative analgesia and intraoperative hemodynamic stability also will be better in combined spinal anesthesia combined with GA for this
Okay,
patient.
so GA, so how will you give, sir? As in, you said first you will give spinal epidural, and for GA, sir, will you intubate the patient or you do
Yes. Endotracheal tube with control ventilation.
Okay. Okay, sir.
These patients with COPD, usually we keep the I ratio a little more, so that to have a longer expiratory time for the patients to completely empty the complete expiration with low tidal volumes. And you can also add a PEEP, because patients already usually have a auto PEEP in COPD patients. So to have a better saturation and everything, you may need a PEEP in the ventilation, around 5 centimeters of water.
Okay,
And
sir.
Tiva is usually better. I usually use Tiva with dextromit, ketamine, and propofol combination. These are the drugs, because most of the time, what happens because of the hyperinflation of the this airways and all parenchyma, there is it takes a longer time for patient to recover from the this isoflurane and sevoflurane. So Tiva is better, and also it does not hamper your hypoxic pulmonary vasoconstriction.
Okay. Okay. So you are in favor of Tiva, sir.
I usually favor Tiva in
Okay.
such obese patients when giving general anesthesia.
Okay. Shiv Kumar, sir, sir, what is your take on this case? How would you go about it?
Is this patient actually has a really got COPD? Now, on what basis was COPD diagnosed in? How do you actually say that this patient is a COPD?
So it's this is for the scenario, but usually, so when the patient has been referred to you by the surgeon and the patient is already started on inhalers, the patient gives a history that since they don't know COPD, so they say they might have asthma,
No,
and the
COPD is
patient is
not
taking
diagnosed by just
inhalers.
history.
Yes, so
Or
they
not,
are.
being on inhaler doesn't mean the patient is COPD. COPD is diagnosed by looking at the FeV1 by FVC ratio. They need to have FeV1 by FVC ratio less than 0.7 to be known as a COPD patient. That is in addition to this symptom. Just because a patient was started on inhaler does not mean that patient is COPD. And if this patient is having saturation 97% and she has got good match, this is unlikely to be COPD. So I would say go ahead and do whatever you want.
And so
the
PFT
wrong diagnosis. No, this patient you need to refine. So either you actually do a PFT and then look at her FeV1 by FVC ratio and say what is that ratio is, and they say okay, fine, this is. go into the history of the patient. Our symptoms might have been just related to obesity. You see patients, I mean, normal build patients who are deconditioned and they will likely get breathless walking, one flight of stairs. That does not make them as COPD patients. Patients who actually have had, respiratory tract infection during the winter time are given inhalers, okay, to relieve some symptoms. Okay, they're not COPD patients. So you need to be very, very clear what is the condition of the patient. Is this asthmatic, this COPD? This is just seasonal bronchitis. You need to know that. Because this patient, she probably was started on inhalers, but she never used them. And she's going on with normal life without inhalers. She's saturating 97% on room air. What you need to do, I will talk about that, is you can actually do some tests. We can actually show what her maximal oxygen consumption is, or whether this patient requires further. There are some very simple tests you can actually do and say, okay, fine, this patient is okay to go ahead, or this patient needs to be referred for pulmonary function test. Okay. And as far as the anesthesia is concerned, I think it's very, very important to actually know the surgical anatomy, right? What is the position of the patient for a laparoscopic hysterectomy? Is the patient supine? Patient is put in terminal position, right? Would you want to give a spinal and turn the patient into the head down position? Would you actually get, even if you give hyperbaric solution or isobaric solution, will it cover the segments? Will it cover? You can ask whoever is there to ask the switch off the mic.
Apart from the speakers, can everybody else please mute themselves?
The admins can actually mute everybody if they want, and they can ask them. Yeah. So you need to be actually very, very clear that how will you able to, because hysterectomy, you are actually going into the pelvis, you are actually got multiple ports, you need to be able to cover that, right? And as far as post-op analgesia is concerned, no, you don't require epidural for hysterectomies, laparoscopic hysterectomy. I haven't seen anybody using epidurals for post-op analgesia. These patients can actually be managed on simple analgesics in the post-operative period. They are, you not touch the bowel in these patients, right? So there is less chances of ILS in this patient, right? So you need to actually think of what exactly the surgery is. Is it, yeah? And again, I think very, very important. I think that, like Dr. Paliwal mentioned, that you need to know your surgeon. How long is the patient? Even say, for example, okay, you decide to actually do it under regional anesthesia. You give spinal, epidural, whatever it is. How long can you actually keep a patient, obese patient, in the surgical position? Will the patient tolerate? Is the abdominal pressure? Now you have the contents of the abdomen pushing against the diaphragm, and you have the pneumoperitoneum. Do you think the patient is going to be comfortable with it? So these are our hypothetical situation, but if it comes to real life situation, you need to actually look at not only the patient, but also look at other factors involved, especially what the surgical position is going to be there. And your analgesia is based on what is going to be there, the pain, post-op pain. Is it actually a painful procedure? So if I were to do this case, yes, I will actually give a GA to the patient. I give blocks to everyone, despite the fact that they are doing laparoscopic. One thing I would actually tell everybody, if you don't know how to do a block for abdominal surgery, learn to do one block, and that is rectus sheath block. That is a port, especially for laparoscopic surgeries. Put local anesthetic on either side of your umbilicus. Okay, do a rectus sheath block. You can do with just a needle and a syringe filled with local anesthetic. And do that. You take away almost 70 to 80% of the pain. The rest of the ports, you can always do infiltration. And you cannot take care of the visceral pain, for which you will need multimodal analgesia. And you don't require anything, opioids or stronger analgesics. Simple analgesics will likely help, which you continue into the post-operative period. Do them regularly and they are fine.
about the
So no, I think in my opinion, this is a wrong diagnosis. This is not a COPD patient.
We had tried to
just
include few googly questions in our case scenarios because we are sometimes not sure what history the patient gives, and we wanted to make sure that we stress on the fact that we need to have few proper investigations in place before we take up any case. So this is one of the scenario that we try to insist on, that we have at least a baseline PFT with us so that we know what we are dealing with. So
Absolutely. I mean,
one
your
thing.
history, your PFT, room air SpO2 is very, very important. There is something else which I'll talk about SpO2 in later on in my lecture as well, which is actually important in these cases, which actually give you indication whether these are real COPD, these are bad COPD or well-controlled COPD. Actually, you can get a lot of information again. And again, the ABG will depend on if the patient. Hey, this patient has got a history of being very sleepy during the daytime, pointing towards, like Dr. Paliwal again said, oh, is this patient got obstructive sleep apnea? You need to look at that side of itself. And then, yes, ABG will actually give you the idea. But the fact that this patient is saturating 97% on room air actually doesn't actually say this is probably just a wrong diagnosis in this case.
okay, thank you,
Just
sir.
one thing I would like to mention about what Dr. Shiv said. Will it cover the dermatomes required for that surgery? So for laparoscopic hysterectomy, what we do is we use two drug techniques, so that there is adequate pelvic coverage as well as some higher levels of block. We use hyperbaric in combination with isobaric drugs.
Yeah.
When the patient is kept in the head-to-head position with lithotomy position, with isobaric drugs, it hardly matters whatever position is given, and they being slightly hypobaric, they don't spread up, they go downwards only. And a hyperbaric drug usually takes care of the pelvic manipulations. So we use in combination to have adequate coverage. This patient may not tolerate the position for more than, say, 60, 70 minutes in the steep head down tilt. So it's better to combine this spinal with some supportive, mostly intubation, because if she has some OSA and the neck circumference is more, even slight sedation may produce some difficulties. So it's better to intubate such patients rather than putting a LMA.
Okay. Okay, sir. So now we have this scenario in which the patient is a known case of ILD, COPD, and posted for emergency appendicectomy. Now, the patient was on inhalers and steroids for ILD, not on any oxygen therapy preoperatively. As he was just able to do his basic work at home, washing, cleaning, and walking a few steps. So around 3 METs were there. On examination, we had heart rate of 102, BP of 110/66, mild wheeze was present, saturation was 95% on room air, the routine blood investigations were normal, echo was normal. Now, we have been asked what all investigations do we want before taking in this case. So, first question is, what investigations would we want? Secondly, what is our plan of surgery? What should the surgeon do? Should we go for an open case, open appendicectomy, or a lap appendicectomy? And what will be our plan of anesthesia? Would we go for a GA or a spinal, as in segmental spinal or spinal? And what if the patient is okay? That will come to later, sir. But as of now, we have been asked what investigations do we need right now for taking this case up, and what should be the surgeon plan B according to the investigations. So, Edward, sir.
So the patient is taking steroids, the patient inhaler, and mid is only 3 to 4. It is less for any surgery. So I will go for ABG and PFT also to determine patient ability. And regarding this open or lap, I better go for open under regional analysis. Because it is a lower abdominal surgery, we can safely give regional anesthesia, spinal anesthesia, or repeated analgesia, and you can do it under open. This is my opinion.
Okay. And Paliwal sir?
This patient is having obstructive and restrictive disorders both together.
Yes, sir.
And surprisingly, his other parameters looks to be nice. So I would like to do his PFT, pulmonary function testing first, whether which disease is prominent, either restrictive or obstructive, because whatever anesthesia you give, the plan should differ according to the dominance of the restrictive or obstructive disease. And whatever the disease is, it is a simple appendicectomy. So according to I would like to examine the patient first, do the PFT, and accordingly can decide. But can very well be done under segmental spinal, whatever the condition of the patient is. I can do it under a segmental spinal. If the surgeon is quick enough, can do it within 90 to 120 minutes. Can be done with single shot segmental spinal along with multimodal analgesia. And the sedation, which I usually prefer in such cases, if required, is dexmedetomidine and ketamine, which is the best combination, which does not hamper your airways and does not lead to the abolition of reflexes plus respiratory depression and anything else. It provides a very good analgesia also.
Okay. Since this is a combination of restrictive and obstructive, sir, if it is not an emergency scenario, would you advise any other investigation apart from PFT and ABG?
No, if it is an emergency situation, you have to deal with anyhow, whatever the condition of the patient is. And after seeing the patient and looking at the patient, you can very well know what type of disorder the patient is having.
So, is there any role of HRCT in this, sir? If it is not an emergency, is there any role of HRCT, sir?
You can know how much fibrosis is there with interstitial lung disease and what the condition of the airways.
And Shiv, sir?
Yeah, this is the unusual situation. We don't come across commonly. So patient with interstitial lung disease, you want to know what is the cause for this? Is this an industrial thing? This is asbestosis? Has the patient got pleural plug disease? Right. And what are the PFTs shown? Now, if you look at the COPD versus, that is obstructive pattern versus a restrictive pattern, they're totally different. And Dr. Paliwal rightly pointed out that, yes, you need to know which is the more significant one. Okay, on what basis was this patient like diagnosed as COPD initially? And then they did X-ray or CT scan and found out that he's also got pleural plug disease or got other causes for interstitial lung disease. And that's what is normally is. So you need to know. So one of the things which is very, very important, I mean, this patient is maintaining saturation of 92 to 95%, which is actually very good. But to diagnose any kind of interstitial lung disease, you need to do DLCO. You want to know how the diffusion capacity is of the patient, how the lungs is. PFT is going to be a bit confusing because it's a mixed disease. You will not be able to actually say which is which. Okay, it's easy to actually say, okay, fine on the FE1, FEC, because both actually are reduced and they are supposed to, ratio is supposed to be normal in the interstitial lung disease. Whereas if you look at the patients with the COPD, you are going to get a reduction in the ratio of that. So where are you? So you can't, so you might actually have this patient with the interstitial lung disease with the FE1, FE ratio actually remaining towards normal, but he is still again. So you need to take a look at the history itself. How much inhalers are these patients using? What kind of inhalers are they on high doses of the corticosteroid, inhaled corticosteroids? Are they on the anticholinergics? Okay. Are they using the SABAs, that is short-acting beta-2 agonist? So you need to actually go through the history very well. I didn't actually get what is she on for her thing?
So she's on salbutamol and butycort, steroids for her inhalers, sir.
Yeah, so this is probably for mainly for our COPD, I think that looks like, and she's not using much of these. So corticosteroids are commonly used for both interstitial lung disease as well as COPD. So even though this might actually look like a bad kind of condition to actually have, she may not be as bad as we actually think. So PFTs usually do, I would actually do PFTs in which they also do DLCO. So you would actually know, how the improvement is going to be in these patients. And these, mind you, this are actually progressive disease. These are non-reversible progressive disease, both of them. So when the diagnosis is made or one of the first initial PFT done, what is the gap between the two? So things can actually change in these patients. You have to again look at exacerbations as well. As a patient required admissions, have they required the use of steroids, oral steroids, or high dose inhaled corticosteroids? You need to actually go more into details of that. And if it says that no, she's been fine, she doesn't get seasonal kind of exacerbations in the winter and things like she actually sails through, then you can actually go for whatever actually anesthesia you want. But if this is actually worse, then this is a case where you will actually book a critical care bed because things can actually go wrong. Either way, whether you go regional anesthesia wise or go on the side of general anesthesia, especially general anesthesia. I mean, I do agree. I mean, for these kind of patient reactive airway diseases of any kind, if you can actually manage without, intubating the trachea, fair game.
And any surgical plan, open versus lap, if the surgeon is okay for open?
I say anesthetics actually doesn't matter to me at all if they are going to go for an open or are going to go for a lap. Because say if you look at the reason for doing an open surgery and a lap surgery, and one of the main things was the lap surgeries have less pain. That is a criteria for most. It's a minimally invasive procedure. It causes less amount of inflammatory response. So that is what surgeon is going to actually, tell you. And if you think that is the way, and if you look at the COPD is an inflammatory disease. And you say, okay, fine, good and well. So I wouldn't actually, they say, okay, fine, you want to go for laparoscopic, I say, go ahead. I'm not going to actually do that. I will actually might change my kind of anesthesia for the patient. Yeah. I will still give them a block, irrespective whether you do it under spinal or do you under block. I will actually always come up with a nerve block. And again, you need to know whether they're going to go midline or they're going to go a classical McBurney incision. So what incision you're going to, depending on that, you actually decide. Yeah.
Okay.
I'd just like to share one scenario. Today only I had a patient, 17 years old female. She was having fever and hemoglobin was 7. She was having some bleeding disorder, polymenorrhagia and all. So her hemoglobin was just 7 and she had acute appendicitis. Also, she had fever. So my surgeon asked me whether just see the patient, whether we can do it lap or open. So what I told him is we will start with laparoscopy if it can be done. It's very good. We just put a port and see what the condition of appendix is. And we did it laparoscopically because the appendix was not very adherent and it was done within 50 minutes. So the patient had the benefit of doing it laparoscopically. She recovered within just 2 hours with just 1.8 ml of isovaric drug around TA11 I gave. And she went to bathroom within 2 hours. And she was okay. I mean, I gave the choice to the surgeon, try it laparoscopically first. And if you think that it's difficult and patient is getting some issues under spinal, so especially these patients with COPD and ILD, then you may have to convert it to open surgery.
Absolutely.
Just put a port and see the condition of the appendix. If you think it's very difficult, taking very long time, and patient is not tolerating your anesthesia, then better go it for open. Along with multimodal anesthesia.
Absolutely. I think as an anesthetist, you should be able to actually, move from one to other.
Yeah, we ask the surgeon to take a consent for open also.
I think most surgeons will likely say that because they don't know what they will find, once they get inside the abdomen.
Yeah, but the problem with recent day surgeons are they are very well accustomed to doing it laparoscopically, but they are very, just poor in doing open surgeries. I mean, I have seen few new surgeons who do it laparoscopically very nicely, but they are, I mean, getting troubles doing it open.
Dr. Paliva, it is same as if the anesthetist has been trained to use ultrasound, they will never be able
Yes,
to actually do a
landmark
PNS
guide.
or a landmark guided technique. So it's, I think, same with surgeons. Those who are trained with laparoscopic robotic, they probably find doing open probably a little bit difficult. And saying that they always get better and better with these minimal invasive surgeries.
Yes.
Okay. So I am hoping that all our audience and all of us have got at least a broad overview of few common scenarios, few uncommon scenarios, and what all we should be expecting at least before taking the patient on the table. We also have one scenario with a BiPAP and emergency obstructed case, but I think we can take it after Sir's lecture because it is on preoperative optimization and a lot of things will be covered after Shiv Sir's lecture. So after that, if we take the scenario, it would be of more help to all of us and we would have a broader view also. And thank you so much to all the three speakers for participating in the debate. And we would try to cover the questions also from the chat box a little later. And we would like to go ahead with Shiv Sir's presentation right now. I'll just change my screen. Is the slide visible, sir?
Am I allowed
Yes.
to actually share? Okay,
Yeah,
I think you need to stop sharing first. You're still sharing your screen.
Yeah, is the CV slide visible on the screen?
No,
Yes.
I don't see anything. Sorry. I don't know what I have done.
China, you need to make it full screen.
Yeah. So now is it visible, sir?
Yes.
Yeah, the CV slide is
It's
visible.
visible, right? Yeah, okay. So let me formally introduce Dr. Shivkumar Singh, sir. So thank you for joining in after your hectic theatre day, sir. And sir is a consultant anesthesiologist from University Hospital, Liverpool. He's a chairman of Theatres and Anesthesia, a specialty audit and improvement lead. Sir is also a clinical governance lead and regional anesthesia lead. His special interests lie in regional, trauma, vascular, education and training, and audit and improvement. Sir is a co-founder of Global Anesthesia Society with 35,000 members and almost 101 countries on Facebook. And we all follow Facebook gas group religiously, sir. And he's a winner of 2023 Northwest Coast Research Innovation Award and also visiting faculty at Harvard Medical School hospitals. Sir has been faculty and organizer for various regional anesthesia workshops for trainees and consultants. He is also involved in teaching and training of students for FRCA, EDIAC, and he uses social media for education for trainees all across the globe. And Sir has delivered more than 500 lectures on various topics and conducted conferences and workshops. And Sir has almost more than 50 publications on various topics and anesthesia and use of social media and education. Welcome, Sir. And without wasting much time, I'll hand over to you, Sir, for your presentation. From all of our seniors on behalf of ISC Borivali, welcome.
Thank you very much. Can you stop sharing your screen? So you have. All right. Are you able to actually see my screen?
Yes, sir.
Okay, so first of all, this year we are actually coming to Maharashtra, to Mumbai for our TechOn 2024. So I would actually personally invite all of you to actually join us at TechOn. We have a galaxy of faculty with almost more than 20 international faculty and nearly 50 national faculty. of great standing. One of the things which we have got workshops, and one of the new workshops we have introduced is the crisis management workshop, which is pretty cheap for trainees. It's only 1,000 rupees. Well, with GST around 1,180 rupees. It's in the Fine Arts Center on 15th of November. And on the same day in the afternoon, we also have trainee posters. And of this posters, 10 of them will be allowed for a podium presentation as well. And there'll be attractive prizes for both. So you have poster presentation or podium presentation. There will be prizes for both of them. You can scan the code, which will be there on the YouTube as well, or you can scan it now, and you can get the details for the registration. So moving on to my topic, so anesthesia and respiratory diseases. Thank you for inviting me to give this lecture on this platform. And this is the topics I was asked to discuss. Discuss about pre-optimization, talk about nebulization, CPAP, BiPAP, intra-op ventilated strategies in patients with comorbidities and other things. Okay. But this is what my this is the way I'm going to discuss. I'm going to actually deal with mostly asthma and COPD, which are the commonest ones. We'll talk about severity and risk assessment and how to optimize them. And I'll talk about anesthesia and related issues. Some of this might be overlap from Dr. Edwards' lecture, but then it's a great recapitulation of what we do. I always say that if you know your why, that's a good start. Because once you know your why, then your what and how will fall in place, or it gives you a kind of a framework, right? Why are you doing this? What are you going to do? And how are you going to do it? Just 3 things. If you know, you're doing well. Okay. So first thing is very, very important. I talk about, understanding the pathophysiology for a disease process, and understanding the surgical anatomy for analgesia or anesthesia. And obviously, as we were talking before, discussing about, do you know your surgeon well, and not only for their, how good they are, but also how quick they are or how slow they are. Respiratory diseases, can we classify into obstructive and, restrictive diseases? Restrictive diseases itself is a big component. ILD is not just one of them. Okay, there are other things, but we will go to the commonest one, that is the obstructive one, which includes our asthma and COPD. So we'll talk about these two in more details. Respiratory physiology is huge. It is very, very interesting. We could go all day discussing about that. So that's why I want to remain focused in this lecture. So if you look at asthma is spasmodic attack of reversible bronchial obstruction. And patient can present with wheeze, dyspnea, and often with dry cough. So the key point here is reversible. This is a reversible disease. And this you can actually see from the FE1 by FEC. Okay, so if you look at the FE1, this is, if you look at before bronchodilator, FE1 is 1 liter per second. But 20 minutes after bronchodilators, it has increased to 2.5, more than 2.5 times. So asthma is a reversible disease, and that is good for us because we can do something about it. Asthma can present from childhood, that is extrinsic asthma, or it can also present in later age, and that is what is intrinsic or non-atopic asthma. And usually in the non-atopic asthma, there are other triggers. They could be even triggered like cold, exposure to cold, exposure to exercise. Okay. So if we go into pathophysiology, if they're looking at more, at the cellular level, you will see that it is type 1 kind of hypersensitivity and type 4 hypersensitivity, depending on what type of asthma you have. But there is often an overlap. And you can see that one in the boxes, there are lots of interleukins involved, interleukin 3, interleukin 4, interleukin 4 alpha. And the drugs are targeted, newer drugs are targeted against this. Their increase in IgE level, their drugs targeting that. Their drugs targeting leukotriene. So we have the leukotriene receptor antagonist. And what happens in these cases, there is lots of mucus formation. So the mucus cells are increased, and that's why you get a mucus plug. There is also edema formation because you see that the mast cells are involved. There is release of mediators, and this causes edema. So there is edema on this in the wall of the alveoli and in the respiratory bronchioles. And there is hypertrophy of the muscles. And that's why you get bronchoconstriction. So the combination of this allergic reaction and the muscular hypertrophy can lead to prolonged spasm. And that's what causes broncho. That's what bronchospasm is. Okay. So you see that there is a component of the type 1 hypersensitive reaction. There are lots of eosinophils within that, but the muscles are also hypertrophied. Okay. There is edema formation. There is increased amount of secretions within the lumen. There is increased mucus formation. Whereas if you look at the COPD is a slowly progressive disease, and it is poorly reversible. So unlike asthma, where the reversibility is very good, here it is poorly reversible. Okay. And this is also inflammatory responses there. So key point is that this COPD is slowly progressive and is poorly reversible. Again, one of the factors which leads to COPD is history of smoking. And you can see it from this graph that FE1 in non-smokers tends to, so that is starting at 25, okay, at age of 25, it's almost 100%. And as you actually go on, FE1 FVC does reduce with age, but in smokers, there's a rapid decline. But if they stop smoking, you can actually have some improvement. So stopping of smoking is a very, very important thing in COPD patients. Unfortunately, a lot of these patients tend to actually continue smoking. We get patients in ours who are like smoking 20 to 40 cigarettes a day. Diagnosed COPD, they're taking all kind of inhalers. So COPD is actually a spectrum. So on one side of the spectrum is chronic bronchitis, seasonal bronchitis, and then it progresses to emphysema, where there's a destruction of the alveoli. And we'll talk about this in a minute. Okay. So if you look at the the mucosa and look at the cellular level, there is numerous glands which are increased in these patients. Okay, but at the same time, there's a reduced number of ciliated cells. Now these are very, very important for clearing your secretions. Okay, then unlike in the asthma patients where there is muscular hypertrophy, there is a reduction in the circular muscle wall. Okay, there's thinning out. There is increased in both serous and mucous glands. Okay, sorry, more on the mucous gland and loss of serous glands. So the secretions are thick, mucus secretions are increased, and the serous secretions are reduced. So it's difficult to get rid of the mucus produced. So large amount of viscid secretions, because like I said, the serous secretions are less, the mucus are more, so it is a viscid secretions. And this is because of increasing globular cells and the mucus cells. But at the same time, there is loss of ciliary epithelium, and this leads to reduced secretions, then more cough and sputum production, and there is episodes of acute bronchitis in these patients. So that is what is happening at cellular level. So what to look at what is happening at the external level as well. What happens to the patient as such? So if you look at a patient with COPD, because they're using accessory muscles, they use a prominent sternoclavicular muscles are present. The shoulders are held high to increase, the breathing, the way they breathe. The chest is barrel shaped. The ribs are almost horizontal. If you look at the chest X-ray, there is liver dullness is reduced because the diaphragm actually pushed down is almost flat. Diaphragm is almost flat. And the heart is covered by the lungs. So you can see these changes in the X-rays. And if you look at the lungs itself, there are actually formation of bullae there, which are mostly in the upper part and in the periphery. And they can rupture and cause pneumothorax. And that's why people are afraid to actually intubate this patient and ventilate this patient. And that's why we're going to discuss why ventilated strategies are very, very important in this patient. If you look at the edges of the lungs, they are rounded. They're not actually, you don't see the costophonic angle and costochordic angles. They are not actually as sharp as you see in normal patients. At the alveolar level, there is destruction. So on the left side, you see a normal alveoli. On the right side, there is alveolar wall rupture. Okay, their ends are retracted. They're distended alveolar ducts. So that's why these patients will develop emphysema. Okay. And there is also, there's chronic inflammation seen on histology of these lungs. And there is narrowing of the terminal bronchioles. So they are obstructive diseases. Now, if you look at now the two in a common respiratory disease, asthma and the COPD. In asthma, it is about increase in resistance. There is increased resistance in COPD as well, but it is mainly in asthmatic patient. Okay, there's narrowing because of the edema formation within the wall. And that's why in these patients, drugs which reduces your edema, so inhaled corticosteroids, they work pretty well in these patients. Okay. Whereas if you look at the COPD patients, there is actually a problem with the muscular wall, okay, forces. So if you've seen how the dynamics have changed, the chest has become barrel-shaped, the diaphragm is moved down, and as well as there is loss of elasticity within the alveoli, and that's why they are emphysematous. So that's what are the changes which are happening in the COPD patients. So these two things are very, very important to understand. The other thing to understand is your changes in the cilia, which are actually seen in COPD patients. In COPD patients, because of the smoking or their exposure to some irritants throughout their life, now what happens is that there's decrease in the ciliary cells. And it's important that the cilia works properly. Okay, the cilia tend to beat towards the mouth so that you can, expectorate the sputum. And there are two layers. There is a salt layer, okay, the serous component, and the gel layer with the mucus component. The mucus component need to move, and important is that this layer, the salt layer, is present. Now, if you look at the salt layer, exactly, if that is reduced, like what I was talking about, then the cilia cannot move properly in that. So for moving the cilia, it's important the hydration is adequate or the salt layer is adequate. If it is too much also, that is also doesn't work very well. So if there is increase in edema, that doesn't work. If there is dryness, it doesn't work very well. So these changes are actually seen. So pre-optimization, okay, again, why, what, and how we do it. So why do we need to actually pre-optimize these patients? The reason is very, very simple. We want to reduce the post-op pulmonary complication, or PPC as we call them. So what we do to do that? So we need to know what are the risk factors for PPC in these patients. What is the severity of the disease, and how well is the control of the disease? So we'll look at the risk factors for PPC, and the ones which are supported by good evidence can be divided into patient-related and into procedure-related. So as the patient gets older, we have seen the closing capacity increases. I'll come back to that again. And they get alveolar collapse even in the sitting up position. So the atelectasis is common with advanced age. Now, patients who have higher ASA grades, patients who have functional dependence, history of congestive cardiac failure, as COPD. Now, we don't get patients who are just plainly, have only respiratory disease, just asthma or COPD. They normally have other problems as well, especially COPD patients, because they are all smokers. They tend to actually have smoking-related problems. So coronary artery disease is common. They would have an MIs, congestive cardiac failures. But procedure-related are actually equally important. So it has been seen that prolonged surgery more than 3 hours increases the risk of PPC, and especially under GA. Emergency surgery, obviously, because patient is not well prepared. And then look at major surgery. So anything which is at or near the your diaphragm. So looking at the aortic surgery, thoracic surgery, upper abdominal surgery, and even surgery like neurosurgery, head and neck, and vascular surgery. And the reason maybe they are complex and they are prolonged surgeries. They are always last more than 3 hours. Okay. So these are important factors to keep in mind. But there are other factors as well. Now, decreased functional status, altered mental status, so patients who are sedated or who have had stroke and things like. Now, history of weight loss more than 10% within the last 6 months is equally important. Patients who have CKD, who have diabetes mellitus, congestive cardiac failure, and significant alcohol use also supposed to have higher incidence of congestive cardiac failure. There is also an scoring system called RSCAT score system. And this I have mentioned a few times in our group. This stands for Assess Respiratory Risk in Surgical Patient in Catalonia. So they say that these factors are important for post-op pulmonary complication, patient developing. So advanced age, which we have already talked about. Reduced preoperative peripheral capillary oxygen saturation, that is SpO2. Respiratory tract infection within the last month, which would obviously mean that patient would have had exacerbation, they would have been on steroids, they would have been on antibiotics. Preoperative anemia, here they say hemoglobin less than 10. We consider 10 is okay for most patients, but they say that hemoglobin less than 10 is also associated with increased PPC. Surgical incision, we talked about that the closer it is to the diaphragm, the worse or the greater the chance of PPC. Long duration, we talked about more than 3 hours, and emergency surgery we talked about. So it has got quite a common things which we have already talked about that. So once we know that what are the risk factors, how severe is the disease in the patient who is coming for surgery, and how well is the control? Okay. So we look at symptoms, right? So is the patient having wheezing? Is the patient got shortness of breath, SOB shortness of breath? Is there a history of chest tightness? If there are none or less than 2 days per week, then they are considered to be well controlled. If they're more than 2 days per week, then they're not well controlled. And if they get it that daily, obviously they are poorly controlled. Then we look at how would they affect their sleep. Are they waking up in the night because of the respiratory problem, whether it's with a cough or bronchospasm? If it is less than or equal to 2 per month, this is considered, well, that's fine. 3 to 4, not well controlled. More than 1 every week is poorly controlled. Then we look at use of the short-acting beta-2 agonist. Okay, so these ones are the rescue ones, salbutamol especially. So less than 2 or less than 2 days per week is fine. More than 2 days per week is not well controlled. And if you're using them daily, when it means daily, it's more than 1 time. Usually, they're poorly controlled. Exacerbations are very, very important. I've talked about it. If it's less than 1 a year, well controlled. 2 to 3 per year, not well controlled. And more than 3 per year, that is a poor control. Okay, that's a frequent admissions. Now, this was actually, again, I think looks at the same thing. I've talked about daytime activities, whether it's been affected, limitation of activities, nocturnal symptoms or awakening if they're present or not. Now, requirement for the rescue reliever treatment, that is the salbutamol we talked about. But what we didn't talk about was the lung function test. That's FEV1, FEC. Okay, is it normal? Is it less than 80%? Exacerbation we talked about. So level of asthma control is equally important. And you have to remember this is reversible. Asthma is reversible. So you need to actually, make sure it is well controlled. Okay. And we look at the therapy itself. Are these patients on, regular low dose inhaled corticosteroids? And if the symptoms are not getting treated, then we actually move on to the increasing the dose. And we can actually add the LTRA, this is leukotriene receptor antagonist. And if there's no response to then long-acting beta-2 agonist, and if there's no response, we actually need to stop and think about things are not going well. And then they need to be referred to the specialist care. So this is what the NICE guidelines actually say. So management is simple. Say, when do you say no? Okay. Poorly controlled, you know how to defer the elective surgery unless it's going to be a life or limb-saving surgery, and you refer to the patient. Simple. Now, this is sort of well controlled. You can continue with elective surgery. You need to continue treatment and probably tweak the treatment, which will come into effect. Not well controlled, well, you can continue with the elective surgery, and you need to optimize the treatment, right? So you need to make sure. So this is a patient who gets symptoms a lot more frequent than the well-controlled ones. So well-controlled, not a problem. Poorly controlled, just refer. Not well-controlled, you need to actually optimize. Well, you need to optimize all respiratory patients. And what is the aim? Aim is to actually have patients who are free of wheezing. No patient should actually come to theater with a wheeze. And if you're looking at the peak expiratory flow rate, which is easy to measure in the bedside, a lot of patients actually keep their track of that. Peak expiratory flow rate need to be more than 80% predicted. So continue normal medication as usual, right? You can actually give 2 to 3 puffs of the usual, salbutamol just before surgery, or 30 minutes, within 30 minutes of surgery, as they come in, to actually improve that. So this is asthmatic patients you are talking about. As for anesthesia, regional, obviously you're not dealing with the airway, you're not doing anything. So we discussed this in the case scenarios. Regional is obviously better. But if you have to give a GA, can this be a short case with a face mask? If not, can it be done with supraglottic device? And last, you have the endotracheal tube. So face mask is considered to be better than supraglottic device, better than endotracheal tube. Because once you are actually going or stimulating the trachea, your chances of bronchospasm, patient going into bronchospasm increase. And I'm sure this has been well discussed by Dr. Johnson, and how to manage that. So we're not going to go into them. Okay. Aim of anesthesia is always to actually have a smooth induction, avoid bronchospasm, and you avoid drugs which can trigger asthma. That is a histamine releasing drugs. Anxiolysis is very, very important, because anxiety is one of the factors which can lead to bronchospasm. So do actually look into anxiolysis. Induction of anesthesia is simple. The best drugs are propofol. Okay, you can add ketamine, low dose, 0.15 milligram per kg. It also helps in the management of pain. You can use fentanyl. Okay, that is considered to be safe. Morphine, pethidine, not good drugs. Lignocaine, you can give 1.5 to 2 milligrams per kg 90 seconds before laparoscopy. Now be careful, especially if you're going to give regional anesthesia. You may want to actually adjust that dose, or may not want to actually use lignocaine. And these are our friends, lignocaine, magnesium sulfate, paracetamol. That's what actually I do. I actually start the case. These cases get, instead of getting the IV fluids, lignocaine 100 milligrams with 8 to 12 millimoles or even 16 millimoles. Magnesium sulfate is added to paracetamol, and paracetamol started as soon as the drip goes in. NDMRs, except for probably, atracurium or mivacurium, most of them are fine. You can use dexamethasone, even though there is release of histamine, but it is still safer. So you can use it for rapid sequence induction. Vecuronium is probably one of the best one. Unfortunately, it's got long action, but there are other drugs which are actually better, cisatracurium and rocuronium. Rocuronium can be reversed with Sigma-Dex, so it had a greater advantage. Volatiles, the king is sevoflurane and sevoflurane both are good, but sevoflurane actually has got a better bronchodilation, especially if you're using around one. Desflurane, forget about it. Okay, can trigger asthma. Saying that, you can always use it for maintenance. There's nothing wrong in it. All volatile anesthetics are bronchodilators, so you could actually use sevoflurane at the time of induction, early phase of maintenance, and take over on desflurane. Desflurane is equally that, but don't use it at induction. Okay. Now, ventilation in asthmatic patients, once they are well controlled, it's not a problem. Okay, you can use volume control ventilation. You can use pressure control ventilation. It's not an issue at all in that. Okay. So if you look at the COPD patients, they are slightly different. They're looking at the compliance is actually increased, because the alveoli, you have seen how they are ruptured, the bullet formation is there, right? So we actually have chances more of barotrauma in these patients. And artificial ventilation, you need to be careful. And that is the most important part of COPD patients. Okay. But we'll come to that in a minute. Tracheal extubation need to be smooth, right? You can use the Bellis maneuver where you put in a I-gel in or a supraglottic device, extubate, let them wake up nice and smoothly. You can use drugs like dexmedetomidine, lignocaine infusion, give them more magnesium, give them beta-2 agonist. Okay. The idea is to actually at the time when they're waking up, there is a smooth transition. They don't actually go, the airways are not that reactive to actually the stimulus of a patient being in light plane of anesthesia, having an endotracheal tube, and going into bronchospasm. Okay. So COPD patients, how are they different? So there is, I think this might have been mentioned by Dr. Johnson about the GOLD, which is, it's their criteria. This is GOLD criteria that COPD is progressive and not reversible, which I have already mentioned that. Thank you. Another important thing, approximately 20% patients with alcoholism also have COPD. That's probably because alcoholics do smoke as well. So I think that correlation is nothing to do with alcoholics, that they do actually smoke as well. Okay. And like I say, it's all about elastic resistances, which are actually changed in these patients. There's breakdown of these elastic resistances, and that's why they have increase in residual volume. Okay. So there are changes in the muscular forces, the way the chest changes because of the increased capacity within the increased residual volume. So the chest is not able to, understand about bucket handle movement, that is restricted, diaphragm is actually pushed down. So those things are actually affecting the way gas exchange happens. And then elasticity within the alveoli itself is also affected. There's breakdown of that itself. Okay. So if you look at the FE1 and FEC, on the left side, you see that the FE1 is 4 liters, so the FEC of 5 liters, ratio is 0.8. So anything more than 80% is normal. But if you look at patient with COPD, you will see the FE1 is reduced markedly, and so is FEC. The ratio here is 0.56, which means this patient has got significant COPD. Okay. So diagnosis of COPD is based on your FE1 by FEC ratio. So any patient who has got FE1 FEC ratio of less than 0.7, that is in addition to all the symptoms, associated symptoms with COPD, that is considered. So going on to severity and control of the disease. So based on FE1 FEC, like I said, is more than 80, it's very mild, 50 to 80% moderate, 30 to 50% is severe, and less than 30% is very, very severe. Okay. So you get concerned when the FE1 FEC is 50% or less. Moderate, you can still actually manage things, but anyone where the FE1 FEC ratio is reduced, you need to become alert. And that's why they say when we were asked about the question, what investigation you would want in these cases, I would want to actually have a PFT in this patient. Okay. But unfortunately, it is said that PFT results generally are not predictive of perioperative outcomes. So if you see the PPC, nowhere have you mentioned that, your FE1 FEC ratio is important for knowing what it is. So coming to one very important or interesting bit is that not everybody would actually have access to FE1 FEC or to the pulmonary function test. Are there different methods of actually knowing them, or knowing that, this is the point where I would actually want to refer and actually get a PFT? Okay, so there are some very interesting and important. So if you look at the VO2, okay, that is the maximal oxygen consumption, that is untrained males, it is around 30 to 40 mL per kg per minute. And untrained healthy females is around 27 to 31 mL per kg per minute. There is something called 6-minute walk test, which even we use, our preoperative physicians, that is our anesthetists use. So this is a distance patient can walk during 6-minute test. And it has got excellent correlation VO2 max. Requires nothing except that you measure the distance within 6 minutes. So you need a stop clock, right? Ask patient to actually walk, and then you measure the distance. So you could actually have 100-meter marked out in the thing and say, okay, let's see how many times you can go 100 meters with a stop clock, 6 minutes, and say, okay, fine. This patient was able to cover 450, so 4 times and a half, and then that is 450 meters. And you divide this by 30, that is your VO2 for the patient. So 15 ml per kg per minute is a VO2 of the patient, right? And that is almost 50% normal in adult females. Or you can have a stair climbing. This is again, as you say, how many flight of stairs can you climb without getting short of breath? So if patients can climb 5 flight of stairs, now each flight of stairs is around 13 to 16 steps. So into 5, so that is the number of steps the patient is able to climb. Then that VO2 max is equal to 20 ml per kg per minute, which is almost reaching the normalcy. Okay. If patient can only climb 2 flight of stairs, that is equivalent to 12 ml per kg per minute. Okay. So these patients, you would say, okay, fine, we need to actually refer them. We're talking about SpO2. Now, SpO2 at room air actually have got no significance. You need to look at the drop in SpO2. Now, if the patient is made to exercise, okay, walk, so you can do that the same thing at the 6-minute walk test. You actually have a pulse oximeter as well. And if there is a drop of more than 4%, then these patients have increased risk of PPC. Okay. And there is another interesting test called 4-expiratory time. And you were wondering what this is. We used to actually have things like blowing a matchstick and things like that. Now, this is actually much, much simpler than that. You don't need to actually put anyone on fire. Lighting a matchstick could be a fire hazard where you throw it in a patient where full of that. So what is FET again? What is it and how it is done? So all you need to do is ask the patient to take a deep breath to total lung capacity. Put a stethoscope on the trachea, ask them to exhale forcefully, and as soon as exhale, you put your timer on. Okay, your stop clock. And if the exhalation continues for more than 6 minutes, you know that is slow exhalation. That happens in COPD patient. Then you need to get FE1 by FVC and refer the patient for further testing. Okay, so I've given you a simple test to actually do where you can actually say, okay, fine. I don't know when the pulmonary function test was there done or not. Let's do a PET test, and that will actually, decide on whether you can be required or not. If it is less than 6 seconds, patient is able to blow out everything. There is no obstructive pattern at all. And whether at the respiratory bronchial levels or LV level, there's no respiratory pattern. So less than 6 seconds is good. So remember 6 minutes, 6 seconds. Okay. So again, why do we need to know? Again, so PPC in COPD patient is as high as 18%. Just a diagnosis of COPD actually increases the risk. And this risk will keep increasing as the severity of the disease increases. And also preoperative acute expiration. So once this patient actually has more history that is they're not well controlled, this delays surgeries. Okay, you do not take patient in patients who are on acute expiration. So what can we do to optimize these patients? You need to ask them to stop smoking if they are smokers. And that means they need to stop smoking for more than 6 weeks before surgery. Just stopping on the day of surgery or 2 weeks, probably not a good idea. Though carbon monoxide can come down easily, but you are not going to get the full effectiveness of that. Okay. So recovery of cilia and gel takes almost 6 weeks. Okay. So give them time. Antibiotics, preoperative antibiotics, and that may be required in patients who have acute expiration or they have a history of increased secretions. Steroids orally, again, this is used in patients who have persistent symptoms. So you can actually give 20 milligrams of prednisolone for 5 days or short course of them. And acute inpatient acute exertion obviously used, but also persistent symptoms should be used. Deep breathing exercise are the main things. I think the preoperative prehabilitation actually has shown that it does make a difference to reduction in PPC. Deep breathing exercises, incentive spirometry, chest physiotherapy need to be initiated in these cases. Okay. And inhalers and long-term medication, you're going to continue as on the day of surgery. And how we do, there's not much difference in the anesthesia you give for patients who are, asthma or COPD. You have similar kind of, goals for these patients. So if you want, avoid endotracheal intubation, but if it is unavoidable, make sure that you don't trigger a spasm in these patients. Like I said, volatiles are the best for these patients. 1.1 Mach is supposed to be most effective. It causes rapid onset of bronchodilation in patients. In less than 1 Mach, isoflurane and sevoflurane, there is not much difference between the two in bronchodilation. Coming to the last part of ventilators and ventilation. Now we have moved from here. So we used to actually have these ventilators, which would just pump in the gases you actually supply. So these are minute volume dividers. So you got 6 liters flow. You get 500 mLs. Okay, airway pressure will be going all over the places, right? The ventilators were just like, they were bellows kind of thing, just trying to push the volume into the lungs. These were not good in patients who had asthma or COPD. Now this is our transport ventilator. Even these are better than those ventilators. There is SIV, ASB, CPAP, ASB, BiPAP, ASB, right? And the anesthesia ventilators can have now, most of them come with volume control as well as pressure control ventilation in this patient again for difficult patients. Some are more sophisticated than others. For example, in this one, you have pressure control, you have volume control, auto flow. You can change the I ratio, you can change the inspiratory time, you can change the trigger sensitivity, right? So more sophisticated. So in COPD patient, ventilation, pressure control is obviously preferred over volume control ventilation. You can get similar tidal volumes at lower peak inspiratory pressures. And it is said that if the peak inspiratory pressure is more than 16 in these patients, then there are increased chances of patients developing post-op complications. And again, expiratory time need to be adequate. So IE ratio need to be actually changed so that there is no air trapping and there's no hypercarbia. Okay. Plateau pressure need to be maintained to less than 30 centimeters of water. IE ratio, like I said, need to be increased. And it also helps in reducing the peak inspiratory pressure. Now, if you look at the graph on the side, the plateau pressure to peak pressure, that is the pressure we required to overcome the resistance. Okay. And that is equally important in these patients. So this is obstructive airway disease. And next comes the important thing. Okay, what happens in the volume? So this is a normal, gap. So everybody knows what is residual volume, expiratory volume. I've simplified this. So you have inspiratory capacity, FRC. Okay, so that is total lung capacity. Whereas your inspiratory reserve volume, expiratory reserve volume, total volume combined with the vital capacity. Now, vital capacity is important to generate cough, right? But what happens in the COPD patients? In COPD patient, you will actually see that's a normal one, and there you have this. So there is increase in the residual volume. And again, in the same way, I'm going to depict that. So if you look at the residual volume is increased, which encroaches on the expiratory reserve volumes, and that means vital capacity is reduced. So you're not able to generate enough force for coughing. They are producing more mucus, the cilia are ineffective, and you can't generate vital capacity. So coughing is inadequate as well in these patients. And there was a discussion about the, I think, intrinsic PEEP and the external PEEP. Okay, so this is called waterfall effect. Now, because there is constriction, there is air trapping, the patient tend to develop IPEEP. Now, you can't measure this IPEEP in normal ventilators, in anesthetic ventilators. You need to actually be able to do as the expiratory hold. If you can do expiratory hold, you can actually measure the intrinsic PEEP. But with normal one, you'll actually have to just guess. Okay. We all know as the age increases, closure volume increases, and the FRC actually comes down, and the closing capacity increases, the FRC, even in sitting position at age of 66, whereas it actually in lying down position is around age of 45. So you are going to get atelectasis in a patient who is more than 45, they're lying down, if you don't apply PEEP. And now in patients, you have to give PEEP to prevent atelectasis. But how much PEEP do you apply in patient with COPD? That's important. And it's important that your external PEEP, that is a PEEP you're applying to the ventilator, should never be more than the internal PEEP. Or it should be around 80%. If you're able to measure the eye peep, then it should be 80% of that. Why? And that will explain. So if you look at this is the normal, like this is called waterfall effect, right? And this is what is happening. Now, if on the right side, so this is where the gases are coming slowly, they are, in COPD, the lungs are getting rid of that. And you actually apply pressure on there, okay, EPAP, right? So you are actually going against that. You're not allowing the lungs to actually, to empty. So this will actually cause more and more of air trapping. So if the EPAP is more than IPAP, you are going to actually cause problems. Desaturation will occur. Air trapping, because of that, hemodynamic changes will occur. So EPAP need to be less than IPAP all the time. Tracheal extubation, deep or awake, depends on you, how comfortable you are. Use lidocaine, that is lignocaine, use dexmedetomidine, use the metered dose inhalers, use belly maneuvers. It's up to you. Okay, what is important is that the patient actually has maximum bronchodilation. Patient doesn't wake up being stressed or, waking up. Some patients who have high anxiety, they find a tube in the mouth, they will actually go completely bonkers. So you need to make sure that they are actually at the right level of that. Okay, so these are very, very important. Now, non-invasive ventilation, prophylactic non-invasive ventilation can be used in high-risk patients. For example, you have a patient, we discussed about a patient who's got obesity or obstructive sleep apnea, and they have had cardiac, thoracic, or upper abdominal surgery. You can actually use, so you can extubate the patient and then apply non-invasive ventilation electively. It has been used to prevent or treat respiratory failure after tracheal extubation. I think this is one of the scenarios which was actually discussed publicly. So where the patient actually has been extubated, goes to the recovery, and then start desaturating. So non-invasive ventilation can be used in these patients as well. And it reduces the need for tracheal intubation. Okay, so you don't actually have to actually then again start thinking, oh, what should I avoid? What should I give to the patient? Just apply non-invasive ventilation. But what are you going to actually apply? Are you going to use CPAP or are you going to use BiPAP? It's a simple thing. A CPAP is for improving oxygenation. If there is CO2 increase in CO2, then in that case, you need to use BiPAP. Now, that is a topic on itself. We need to talk about it. You can ask me that. I can discuss that on the gas platform. Okay. And work of breathing, it's, different ventilatory mode has got different part of it. And spontaneous ventilation is always considered to be better. It's a kind of where the work of breathing is provided by ventilator, some amount by patient, and it's a good compromise. And it also provides the best hemodynamic in the patient. So coming to the end of the lecture, summary-wise, know your why. Okay, if you know your why you're doing it, why do you need to actually look for what investigations you need to do will depend on what your question is. Okay, how you do it, it's up to you. You can use non-invasive methods. Okay, and always understand the pathophysiology of the disease. Okay, you should know how to risk stratify this patient based on severity, and know how well is the control of the disease, or what do you need to do to control the disease. Because once the patient is well controlled, then everything is easier for it. Problem occurs when we actually have patients coming for emergency in an uncontrolled situation. That's a different thing. Okay. You need to have define your goals of anesthesia. Like you say, I want patient whose peak expiratory flow rates are more than 80%. There's no wheeze. Patient is saturating well. Okay. And use drugs and techniques appropriately. Okay. You need to know what you need to avoid or what you can use. Okay. So thank you for listening to this lecture. There is lots more we can actually discuss in this topic, but I think it's better left for another day and to a question answer session.
Thank you so much, sir, for the amazing presentation. All our scenarios, which we had few tricky questions, were solved. How about COPD? Why PFT? What about NIV? So likewise, you said that we had kept that last scenario about an emergency situation. If a patient who is dependent on a CPAP dependent patient coming for an emergency surgery, and what should be our plan of action? A lot of it has been covered by you, but just in case, if we come with that situation, what are the red flags prior to extubation that we should be looking at? If we have intubated the patient and we are the patient was CPAP dependent preoperatively, what do you think should be the red flags that we should look at, sir?
Yeah, so I think the intraoperatively one thing is that what is the end-tidal CO2 doing in these patients, right? How well the end-tidal CO2 was been able to control with your ventilation intraoperatively, right? Then obviously oxygen saturation, which is not a difficult thing to maintain, but there will always be situations. I have actually faced myself not knowing that where, the patient has kept desaturating, and then you realize that the PEEP you're using is more than probably the patient intrinsic PEEP. That's why the patient is desaturating. So saturation is there itself. Then in emergency situations, somebody who is BiPAP dependent, you wouldn't do it without an arterial, having arterial line where you're monitoring your blood gases.
Okay.
And you look at the CO2, you look at the pH of the patient, is the patient in that, and how well the oxygenation is. So it's about, like I said, the COPD patient on, if they're early stages, they're fine. When they come at later stages, they usually have other medical problems as well. A lot of these patients would actually have cardiac disease, coronary disease, maybe must be in congestive cardiac failure, right? These are kind of patients you need to actually have booked a at least level 2 or level 3 bed. Because this is the kind of patient you might actually think, I'm not going to extubate this patient. I'm going to actually keep this patient ventilated. I'm going to have this patient a gentle, awakening and extubation in a safe area. And the safe area is a critical care area.
Okay, correct. Okay, sir. And we would like to take the questions from the chat box. Somebody has asked, can you please talk about lung recruitment maneuver in COPD?
Yes, you can do it on ventilators, but that is only not on anesthesia ventilators. That is in the ITU ventilators. But lung recruitment in the COPD patients on the anesthesia is by hand. All right. So you need to actually take the patient on manual ventilation, increase the flow, put the PEEP on the APL valve, okay, clamp it, okay, and give a sustained pressure on the bag. So bag is filled up, you sustain this thing, and you will look that initially it doesn't climb. Actually, the saturation will actually start dropping, and then it will actually start climbing up. So it is done manually. You don't do it for more than 15 to 20 seconds, okay? So you sustain that, leave them, right? But there is something, again, if that is not happening, say, for example, you are trying to recruit and say the patient is desaturating, actually, what do you think is happening? Okay, and I'll tell you the answer. I disconnect and the saturation goes up. Okay, this is exact example of that. You actually are applying external PEEP, which is actually more than internal PEEP.
Okay, yeah.
So there's nothing going in. Now you actually have 2 levels, right? So this is internal, what is there. So this is the water flowing, and you have water flowing from this side. Now, if this level is high, nothing is going to go in, right? This need to be lower than that. And one of the ways of doing it is to actually empty the lungs, is to actually disconnect and let the lung collapse, reconnect, and then actually go for it. And you'll see saturation improving. Right. So if recruitment is not working, you think, because if you see normal patients, you apply recruitment, within seconds, the saturation will climb. But in COPD patient, it will not happen. Okay, it will not happen all the time.
Okay. Okay, sir. And one more question is that if a patient who is diabetic and has been posted for lap surgery and we put in an LMA, what is the risk of aspiration in case of diabetic gastroparesis?
Yeah, so yes, you will actually have increase. It depends on for how long the diabetes has been for, whether the patient is actually on insulin. So gastroparesis, you will actually know from the history of the patient. The patient will actually also have autonomic signs as well if there is gastroparesis in these patients. In these patients, if you're using a supraglottic device, right, you need to actually ensure that there is angiotuba and it's on free drainage. I use it for a lot of time in diabetic. It's not a contraindication. CKD patient is same again. You can't. But if you also look at one of the greatest advantage of laparoscopic cholesterol patient is that they go head up, not head down. Right. That is working to the advantage. Your lungs, the abdominal contents are not pushing. The only thing which is pushing the diaphragm is the intra-abdominal pressures by the insufflation. So this is an advantage, having the patient actually sitting up. But if you're going for a patient like you're discussing on where the head is down, I would better intubate and not think of putting a iGel or any other second generation supraglottic device in these patients. Irrespective of whether you're putting NGT or not, the risk will likely remain. So think, like I said, you need to know the surgery as well. You need to know what pressures. There are surgeons, some surgeons which use very low pressures. They're absolutely amazing. Pain is much less in these patients. They actually tolerate anything much better. But there are surgeons who would actually want to use high pressures. Those are bad cases. In those cases, just put an endotracheal tube. So knowing your surgeon, how quick it is, how good they are with low pressures, that is equally important. For anesthetists, knowing the surgeon is equally important as knowing the surgery.
Okay, sir. And these are some questions from YouTube. For Paliwal, sir. Sir? Yeah. What is the dose of isobaric bupivacaine if we want to give for lap cholecystectomy at T10 level?
It depends. If you are giving at a slightly higher level, even a dose of 1.2 to 1.5 ml can do, depending on the condition of the gallbladder, the surgeon, how fast the surgeon is. I usually use for my surgeons. I know my surgeon will take around 60 to 70 minutes. So around 2 ml I use at T10 level. The lower the dose, higher you have to go. I mean, if you are giving a dose around 1.2 to 1.5 ml, you need to go at around T7 at 9. Or if you are giving a little higher dose, or even you can use a two-drug technique like hypobaric and isobaric, because the patient is in head-up position. So hypobaric drugs will take care of the shoulder tick pain, and you can use a very low dose of isobaric or hypobaric. So depending on the surgeon, surgery, and the condition of the gallbladder, you can choose your technique.
Okay, sir. And one more question for you only. What is the role of segmental spinal in pediatrics? Is it safe for use in pediatrics?
It's being done very often, actually. Dr. Rajesh Shah is doing a lot of pediatric spinals. I have done many cases, pediatric spinal. And I have also formulated a gas formula, actually, for pediatric patients for segmental spinal.
You
So
shared it on the gas platform, isn't it?
Yeah, I shared it and named it as a gas formula for pediatric patients using segmental spinal.
Okay.
It's there, I think, in the.
It is the age in years divided by a fixed denominator. For 2 to 4 years of age, it is age in years upon 6. For 5 to 8, it is age in years divided by 7. And for 9 to 12 years, it is age in years divided by 8. Equal to ml of the drug.
ml of the drug total?
Yeah, total.
Okay.
You can modify it according to your surgery a little bit. But this is a gross dose information about the pediatric patients. It comes to around 60% of the dose used at the lumbar levels.
Okay, sir. So one question for Edward, sir. If a patient who has ILD and also has pulmonary hypertension moderate to severe is posted for inguinal hernia repair, how would we go about it?
Definitely, we have to go for a general anesthesia control ventilation because the patient is having pulmonary hypertension. Any hypoxia, hypothermia, and acidosis will increase your pulmonary hypertension. So definitely, we must have a control over the ventilation. Then only we can control the hypoxia, control hyperthermia, acidosis, and thereby reduce the pulmonary hypertension. So definitely, it is general anesthesia with endotracheal.
Yeah. And we can give a hernia block along with it, so as in ILH for analgesia.
Suppose we are giving hernia under a regional anesthesia. Suppose the patient is going for hypoventilation because these patients are ventilatory response to hypoxia hypothermia is very less. So they are likely to go for hypoventilation. If we go for hypoventilation, your added risk of hypoxia hypothermia will definitely increase the pulmonary vascular resistance.
Is that open or laparoscopic hernias?
I think it is laparoscopy.
Yeah, I'm assuming it was from YouTube, sir. So somebody
Okay,
has posted.
because open surgery can be done in various
Open
ways.
surgery,
There are
Yes.
many different ways in regional, right from the ilioinguinal, iliohypogastric, and this genitofemoral nerve block to paravertebral to isobaric to hypobaric to hyperbaric. There are many options in which it can be done very safely, even tab block with some sedation, local infiltration. And
think they
doing it
mentioned-
laparoscopically, there are high chances that a patient may have this subcutaneous emphysema, which is very troublesome. Extraperitoneal, when they do extraperitoneal hernia repair, the CO2 goes on rising many times. So that can be a troublesome.
Absolutely.
Whatever mode of anesthesia you give, the CO2 starts rising.
And so one more question, can there be a role of continuous spinal put a day prior to CABG or other cardiac surgeries versus epidural? Though erectospiny and other blocks used, but we're curious about the easiness and effectiveness of continuous spinal in perioperative management and cardiac surgeries.
About use of single shot spinals in cardiac surgery is well mentioned in various literatures. About using the continuous segmental spinal for post-op analgesia, you need a proper setup for handling those catheters, proper sterile precautions and everything. If in case you have an accidental dural puncture during epidurals, you can very well convert it to continuous segmental spinal. And if required for post-op analgesia, then only if you have a setup, proper staff and proper labeling, then only you use it. Otherwise, you may misinterpret as a epidural and high doses can be given. So better not to use it if you don't have the proper setup.
Okay. And I think most of the questions have been covered from the chat box and also from YouTube channel.
There was a question about the kyphoscoliotic patient coming for.
Yes, I think you answered. So, okay.
I would like to have the
yeah,
opinion of Dr. Shiv and Dr. Edward on the same.
Sorry, I didn't
patient.
get that. Scoliotic
I'll
patient?
see the question, sir. Yeah. So
In the
there
chat
is
box, there is a question.
pregnant patient with severe kyphoscoliosis for elective LSCS. Patient cannot lie down, couldn't lie down because of respiratory issue. So how do we go about it?
If the patient can't lie down, then you need to actually give a general anesthesia, isn't it? There is no contraindication to plan B for any of the regional anesthesia is going to be a general anesthesia anyway. But if the patient cannot lie down, okay, then you have to actually go for a general anesthesia. I mean, yesterday itself, I posted a case where it was just a second stage of BVF, the brachiocephalic fistula, second stage. And this patient had severe congestive cardiac failure, and he was CKD. He couldn't lie down. I mean, we moving from the bed to the table, he was like breathless, short of breath. So if the patient cannot lie down, how can you actually think of actually, having a patient with a spinal anesthesia? I can understand spinal anesthesia is much safer in cesarean section patients, but if they are not, they cannot lie down at all with such kind of thing, it is difficult. And second thing is that if the patient with kyphoscoliosis is not able to lie down, that indicates that patient probably has got severe pulmonary hypertension, which does develop in these patients over a period of time. Normally around 35, 40 years of age, they actually start developing severe pulmonary hypertension. So is that something else going on? And even if you actually, you can still likely say, yes, spinal is better. Okay, what if you gave spinal and still doesn't work? You will still need to actually have plan B for putting her to sleep. It is going to be tricky. You need to be in kyphoscoliotic. How are you going to position the patient for intubation? Intubation also is not going to be easy either. Okay.
And sir, in this case, then what would be the extubation criteria?
So extubation, again, like I said, these patients, if there's non-pulmonary hypertension, the patient hemodynamic is going haywire through the procedure, I would actually put an arterial line and send this patient to the intensive care and let them actually wait. They might actually require much more. They might even require like inhaled nitric oxide or giving prostaglandins through the prostacyclin through the endotracheal tube and things like that. It will depend on how the patient actually behaves intraoperatively. Now, if the patient actually has no pulmonary hypertension, right? You gave a GA, patient actually did, everything is fine, end-tidal CO2 is maintained with normal ventilation, oxygenation is fine. You reverse the patient, right? And extubate them as you would normally do. I know a lot of people actually don't use neuromuscular monitoring, but neuromuscular monitoring is the most important thing in preventing post-pulmonary complication PPCs. Inadequate reversal is the commonest cause for PPCs in patients, irrespective of whether they have COPD, asthma, or not.
Okay, sir. So I think most of our questions have been
This
covered.
strategy actually advised for all patients when you extubate is to continue for some time NIV after extubation. See that you have a complete reversal, adequate analgesia, and humidification and everything is maintained, and just keep the patient on NIV for some time, NIV support, whatever the condition of the patient is, even if it is fully conscious, just to avoid the reintubation for such COPD patients. Best.
You don't even need a machine. You can actually use your simple face mask, APL valve, leave it on. Okay, patient comfortable on the bed, sitting up, put the mask on, let them breathe. Take your time. Don't be in a rush. Okay. And always, I think these kind of patients where you actually have emergency surgeries, history of COPD, or patient like severe kyphoscoliosis, not able to lie down, things you need to actually also have a backup of a critical care bed. There are high chances that these patients will either you won't be able to extubate, require reintubation, right? Or it's like you said, decided, let's have a smooth extubation in the intensive care. In case things go wrong, they are in a safe place.
If the patient is preoperatively dystic and lying down, or difficulty in breathing, or anything, patient is persistent cough and lying down, these patients are ideal for general anesthesia, as Sir said. The patients will not lie down comfortably in regional anesthesia. And regarding the extubation, I will not rush up to the extubation because the patient is preoperatively dyspneic. So I will stepwise. I will go for elective ventilation, then go for CPAP or BiPAP, then I slowly extubate. So relieve the patient from the ventilation. So don't rush for ventilation, extubation. Yes, sir.
For that patient of kyphoscoliosis, I have actually mentioned a very different approach. Put the patient on NIV in the sitting position, then give spinal with 2 drug technique, just hyperbaric 0.5 and isobaric. It will not go very high. Keep the patient in a slightly head-up position after giving Dexcate as a sedation, so that patient can lie comfortably with a slight head-up tilt, so that isobaric drug will spread, will not have the problem of not achieving the adequate levels. And then LSCS can be completed with multimodal analgesia.
I mean,
I don't think this will be feasible if after seeing the patient, you can think about the other this thing. This is just theoretical.
Can I tell you how I did the case? I think it was too much of a risk I took, but I did it. So the patient could not lie down only in the last week, probably because she was full term.
Okay.
So what I did was I gave routine dose. In any respiratory cases, I usually give lower dose of spinal. But I gave, in this patient, I gave routine dose. So 2.2 ml in for the section patient that we gave, I gave 2.2 and gave her a head up. So I gave the spinal in sitting position, then gave her a head up. So the level was achieved. and
Right.
gave oxygen throughout. And once the bachu was out, patient was
Things better.
better.
Okay. Yeah.
So I could manage this, but I just wanted to know, is segmental spinal a good thing option? Means this was many years back. So at that time I was giving only spinal. Now would segmental spinal be a good
Yes,
thing to give? And
that's
when the child is out, I think the patient would be more comfortable. That
that's
is,
what I said. Ki with
yeah.
giving 2.2 ml even with a patient in a
Okay.
slightly head up position, you may not achieve the adequate levels. You may need
I
some
got it, sir.
supplements.
No,
So
I mean,
what you can use is two-drug technique. The hyperbaric will go down, the isobaric will go up, and you will have adequate levels. And plus, you can use Dexket as a sedation to make the patient comfortable in a head-up position.
okay. Yeah, so that's what I wanted to know about the segmental spinal part. And if the spinal would have failed, how I would have given G, I don't know.
No, that is a backup plan always. You
First.
need to have that.
But in kyphoscoliotic patients, would a segmental spinal be difficult? The thoracic
Yeah,
level
you need to go from the convex side.
from the convex side.
Yes,
Right.
convex side is more easier. Whenever
Okay.
you go in the scoliotic spines, convex side, you always use a convex side.
Yeah.
Because going through the concave side,
space is
you need to
open.
go quite deeper.
And yeah, you need to go deeper, and the space
And
is
if
more
you have
open.
ultrasound, then you can always use those for your assistance.
USG might help.
Yes,
So
USG
this
guided can be
actually
done.
brings us to the question is that, you need to understand the pathophysiology, why they is the patient, because that wasn't mentioned that, oh, this patient became breathless only in the last few weeks of this. That would have pointed out to us that what are the causes. So that's why it's understanding the whole pathophysiology.
No, she was breathless all throughout. She was breathless all throughout, but in the last 1 week, she couldn't even lie down. So I presumed it was more because of the pregnancy and full term, because she was breathless. She was badly kyphoscoliotic. So they
Maybe
have
large
this
size baby.
test, and she was quite bad. But I just kept my fingers crossed and I gave the spinal. I gave routine dose, gave her head up, and once the child was out, she was at least more comfortable and kept a little head up only, and we could get through. So yeah, but I don't know what I would have done if, I mean, it would have been a difficult thing if I had to give full GA, and she was really bad,
Was the spinal difficult?
Because of the
Kyphoscoliosis?
Yeah.
Was it difficult or easy?
Yeah, it was difficult. I got it after 2-3 attempts, but I got it, fortunately.
You are lucky that the patient becomes less dyspneic after giving spinal and able to lie down.
No, she could not lie down, sir. She could not lie down. I just gave her one pillow, let her lie down, let the level come up a bit, and then immediately gave her two pillows so that, the level wouldn't go up and she was comfortable lying down. So I gave her almost, it was like a propped up types only. They got the child out immediately, but I know it was a risk what I was doing.
What segmental spinal has done actually, it has opened up the whole spine for giving spinal. You can choose your drugs according to your level of injection. You can choose isobaric, hypobaric, hyperbaric, whatever things. It's not restricted only to the L2, 3, 4 level now. You can go higher up and choose your drugs accordingly, according to the situation, according to the patient's comorbidities. So it can be done very well, actually.
Pretty late at night in India now.
Yeah. Before you do the formal vote of thanks, I thank all the three speakers. It was an excellent presentation. Especially on behalf of Dr. Shiv, I would like to ask everybody to register for TACON. From IISc Borivali, we have almost 5 members who are there in the committee. Shilpa Tivaskar is there, Ganesh Tendulkar is there, myself, I am there, and Kriti Kanojia is there, and Kala is also our part of our own we call her a BSA member only. But so I request everybody to register for SECON. It's going to be a fantastic. Thank you, Steve, once again for being with us today.
Thank you very much. And like again, I personally invite you all to take on in Amchibumai. let's have a blast in November.
Yes, sir. With this great academic feast coming to an end, I would just like to propose a vote of thanks. Most importantly, thanks to the SAMS office bearers, that is Society of Anesthesiologists of Maharashtra State, that is ISA Maharashtra, for providing us this Zoom platform and this opportunity to interact with national and international speakers who would be like superstars in themselves for each conference, and all of them coming together just for a city level CAB, I would say. It's our good fortune, and I would like to thank the speakers personally again, Dr. Shivkumar sir, Dr. Paliwal sir, Dr. Edward Johnson sir. It's because of you that we got to know a lot of things together. I mean, today, lots of confusions got cleared. Your presentations were superb. Thanking the team of Jenica who's given this platform to us, and our participants, all the delegates, the team of ISA Borivali, which has worked hard in preparing the background and everything. And last but not the least, our MOC for the day, Dr. Chana Desai. She is not in India right now, but she still managed to conduct the thing properly. Once again, thanking everyone, and hope to see all of us, like sir said, in TACON again. Let's see. Thank you very much.
Bye-bye. Good night, everyone.
Thank
Thank
you.
you, everybody. Thank you, sir.
Thanks, everyone.